All right. Hello, everybody, and welcome to the DATAcated Health Conference. Super excited to be here with you today. And because it's a DATAcated Health Conference, I was thinking we'd have some fun. And, how else can we inject fun into the conversation other than bringing some fun speakers with us? So, before we get started, I just want to let you know this is a live conference. And what does that mean? That means we get to talk to each other live. So, if you're joining us on LinkedIn, YouTube, Twitter, Facebook, or Twitch, make sure you say hello in the comments, network with each other, ask questions. We're going to take questions via the live comments that are coming in on all of those social media platforms at the end of each speaker's presentation. And, data is the heart of all organizations. So we have to make sure we take good care of data. And, I heard it sounds like it's going to be a fun event today. So the heart of our conference today is the speakers. And I really can't thank you guys enough for taking all your time and effort, taking the time out of your schedule to not only show up, but also to prepare in advance to help us promote the event. I truly, truly appreciate everybody doing that. My name is Kate Stashny. I'm the founder of DATAcated. I will be your host for today. And for the next couple of hours, I'm hoping we not only learn a lot from each other and from the speakers, but also get to know each other, build those relationships that we can nurture throughout the rest of our career and the rest of our life, really, and have some fun. So we're also going to have giveaways. So brace yourselves. It's going to be a fun couple of hours. As I mentioned, we will take questions from the live audience. We're also taking comments. So if someone's saying something that you agree with or disagree with, go ahead and drop that in the comments as well. Before we begin these sessions themselves, I'd love to ask everybody here for your support. If you enjoy the DATAcated shows, the DATAcated conferences, and all the stuff that we do for you, then just go ahead and like or share this post so we can get more folks in here to not only view the show, but also to interact with each other. Before I bring up our first speaker, I'm going to tell you about our giveaway. So our giveaway today is the DATAcated Circle, and the way to play is just type in hashtag DATAcated into any of the platforms that you use to join today. So what is the DATAcated Circle? It is an online community and course platform. We have courses on going from data to dashboard with Tableau, Power BI, Click, TIBCO, and many other tools, and as well as R and Python. And it's also an online community where data professionals gather to talk to each other. So we're going to announce 3 winners after our first speaker has concluded. So just type in hashtag DATAcated and we will make sure to play. Just going to check in on the comments here. Let's see, we've got lots of folks joining. Hello, hello. We've got London. Hello, Jorge. George from Nairobi. Chile, Jersey Shore. I'm in Jersey as well. All right, awesome. We've got Florida. So thank you so much for joining. I see the hashtag DATAcated are coming in, so I really appreciate that. Keep those going. I'm going to go ahead and introduce our very first speaker in just a second here. All right, let's go ahead and shared the wrong screen here. I'm going to go ahead and introduce our speaker in a second. I want to share my screen so you could see his name and you could see his face as I introduce him. His name is Alexander Izaguirre, and he's going to talk to us about improving healthcare with data hubs. Alex currently serves as the Chief Data Officer for Weill Cornell Medical School and is charged with developing a comprehensive data and analytics vision aimed at helping the missions make better data-informed decisions. Previously, he served as the CDO for New York City's Health and Hospitals Corporation, the largest public health system in the United States, where he led the rapid development of key solutions supporting situational awareness, clinical operations optimization, and resource/staff planning for the largest medical emergency of our lifetime. I think you're probably familiar with this medical emergency, the COVID-19 pandemic. He served as assistant professor at Baylor College of Medicine, as well as the Robert Wood Johnson Medical School, where he taught immunology to medical students and to physician assistants in training. In addition to his PhD in viral immunology, Alex holds an MBA and Bachelor's of Arts in Biology and Psychology and a minor in mathematics from Rutgers University in New Jersey. All right, I'm going to go ahead and bring Alex up on our virtual stage here. Alex, welcome to the DATAcated show / conference / DATAcated health, whatever we want to call this thing. Welcome.
Thank you, Kate. Thank you so much. And I'm really happy to be here. I'm As I've told you many times before, I really love the work that you do, and this effort is really valuable to so many different people. Today, like you said, we're going to focus on talking about data hubs.
Mhm.
Before we really get into the data hub thing, I really would like to kind of set the framework or the background up. Part of the slides that I'm going to show here, we're going to start with what we've done internally as an enterprise data and analytics shop at New York City Health and Hospitals. Uh, what you'll see is that for a big comprehensive program like what New York City Health and Hospitals, there's various different layers. And I like to level set a little bit here because what's important is that we're all accessing data or in engaging data at so many different levels. You can be a data consumer who is looking at dashboards and reports and just trying to interpret things and understand those things. And for you, that means something different than someone who is like a data champion who really wants to learn the details on how to manipulate data so that you can generate your own dashboards and reports and data models and things like that. And then on the other side of the world, you could be an executive who's looking for information for situations like the pandemic and others where you're just trying to make decisions. In the midst of all that, you're tapping into resources at various different levels. And what this slide shows here is how we go from the source data to actually building a data solution, which is like your dashboards, reports, extracts, and analytic models and things like that. So to the left, what we see is various different source systems, and every company has their own set of source systems that they leverage. At Health and Hospitals, we actually have over 300 different applications that we use at an enterprise level, and then many, many more that people are purchasing individually. But we work at bringing that data through what we call data pipelines into our data platform. Our data platform there was built on Snowflake. We used Informatica to bring that data in and also to organize it in a manner where people can, view a catalog and see what data that we have. Now, much of this data isn't generally available to everyone. You can make requests to get access to that data, but the groups that do have complete access to it are analytic cores. So if you'll see on this, you have a pillar that is the DNA service provider pillar. We have a clinical excellence core, a corporate reporting core, a financial sustainability core, and any organization can organize themselves as they see fit so that they can build data solutions for their customers and provide the resources needed to make the right decisions at the right place and the right time. But on top of that, you can actually have the data as a product. So people could ask for data just so that they can tinker around and try to do their own analysis and things like that. Now, this model has worked really well for an institution of our size. New York City Health and Hospitals has 50,000 employees, more than 50,000 employees, and trying to provide service to that many people, you have to have various different levels of service. The analytics cores focus on the needs of the executive sponsors. The ambassador program focused on the needs of the data champions, the people that want to do things more on their own. And then we had the self-service platform that we built that provided service to the general data consumer, which is the majority of people, making it easier to search for dashboards and reports and request access to them if they are not available to them. So, like I said, this model definitely makes things a lot easier and streamlined for an organization, enterprise of this size. But what happens now if you're in a situation where you need to be working with other entities? This starts becoming more complicated. How do you get that data and other people's data together so that everyone can benefit? So, for example, New York City Health and Hospitals working on a very important initiative called Special Populations, where we're trying to support the homeless and create better services and be more aware of all the different things that might be needing from a housing perspective, or food vouchers, and all sorts of different resources that are important to take care of our most vulnerable in New York City. And in doing that, the data is going to be really important to not just get from health and hospitals, but from other agencies. So how do you bring that together? And that's what really leads us to the core of our discussion of Data Hub. So what you'll see is typically in situations like this, and this is just a diagram that shows the complexity of not having a data hub. What you'll have is various different organizations, potentially in different regions of a city, a state, a country, or even in this case, continents, where there's different point-to-point connections being made where people are sharing data. Now, this tends to become a huge mess, both from a governance perspective, a technical perspective, and even just kind of data integrity perspective. If people are moving around files or sets of data, asynchronously at any time, when you're looking at a dashboard or report that's generated as a result of that data, it might be different from something that someone else generated, even with the same data, just because it's a different time frame. So it's very hard to actually leverage this data in a useful way without having a lot of debate as to whether what you are developing is correct, just as a result of all the different point-to-point connections. So this environment really has a lot of overhead. So how do you collapse this into something that's far more manageable? And that's what the Data Hub does for us. So here, what you see in the Data Hub is you see this come together in a different way. Instead of everything interconnecting with every other source, what you do is you either create a global hub or you create regional hubs where data are aggregated together and then again brought back to the global hub. And this becomes really, really powerful because data goes into the hub, but also the data that comes to the hub can be made available to any of the participants, as well as other groups that are not even adding data. And what you do now is you have the ability to be looking at the same data and leveraging the insights that anyone has, ubiquitously across the entire environment. And this saves you time, it saves you money, it limits complexity, it limits expense. So it is an architecture and approach that is far more helpful than just trying to have your own data and saying, well, we'll just share with every partner and receive from every partner. It's minimizing that duplicative effort. So with respect to what the city's trying to do here is it's trying to aggregate some of the data sources from various different participants throughout the city, different agencies. And again, in the interest of working together with everyone, it's not just one directional. It's something that all the agencies will benefit by adding data into the hub. So we believe that we can see more clearly what's going on with the different patients that we're trying to follow their journey and see what's going on with where the things are being held up, where they're not getting the right level of service or support, by working with all the other agencies and creating a unified view of the patient and their journey through the life cycle with the special populations. So with that said, I think we have some time for questions, and this is really exciting, and I really love that we've been able to take the foundational infrastructure that we invested in at Health and Hospitals and turned it into something that can really help far beyond the walls of the actual hospital system.
Absolutely. Alex, thank you so much for the presentation. I do have some questions, and I see questions coming in from the audience. So thank you for helping us kick off the event, and thank you for sharing this. It really looks like data hubs can help reduce complexity. And I know you mentioned that we can pick between a regional data hub versus a global. So just wanted to ask, how do we know which one is better? When do we use a global versus regional hub?
I think that's a great question, and there's a lot of nuance in that from the perspective that in some settings it could be architecture-wise and speed and what you're trying to do technically that might warrant building a more regional hub. In other situations, it could be from a governance perspective and the different partners that you're working with. So if you have relationships with certain organizations that there's a lot of less, I guess, bureaucratic friction, you can build a regional hub with them. And that might even be a great way to get a hub structure launched, because many people are hesitant to try something that they haven't seen done before. But if you can get the right partners together to do something like this, then like, hey, why aren't we doing that? And then you see other hubs build, and then you can interconnect them. So it really is an organic type of solution that gets developed.
Okay, thank you for that. We'll go to the audience for some questions. I see John O'Gorman has one. His question is, how was semantic interoperability between and among the 300 enterprise level applications achieved, and when in the hub process did that happen?
So that's a great question. The semantic interoperability is actually occurring on a case-by-case basis. So actually, it happens on two sides. One, we have a data model that we've developed that we are bringing everything into, and that's how the source data comes into a staging area. And from there, we curate and clean up some of that data, and then we merge it into a model that, from a governance perspective, the institutions have defined the measures, metrics, and KPIs for. The other side of that story is, and we have to be nimble, and this is why I say this. From a practical perspective, one thing is building your data platform that has all of this stuff in here. And then on the other side, what you have is customers asking for dashboards and reports. Sometimes we build something quickly just because there's an immediate need. We aren't going to tell our doctors that are interested in info for monkeypox that, hey, you'll have to wait till we get the data into the perfect semantic structure into the data platform. So we build those things out, but now we are developing some technical debt. And then over time, once we've gotten those definitions ratified, then we merge that into that structure. And now we can update those dashboards and say, based on the definitions that we've now come up with, the data might look a little differently, but this is what we really have. So now to the last part of that, the hub doesn't affect this. The hub is a logical construct that occurs outside of this from a logical perspective. It's using the same technology infrastructure, but we are now making relationships with partners, leveraging some of that data, carving out a section of our Snowflake platform to build out that hub.
Okay. Awesome. Thank you. We've got another question here from Ben. He's asking, how do you model data for it to be consistent across regions?
That's really a great question. So that's the point of the hub exactly. So you want to, this is not an effort to bring, and I love that question because it brings out a point that I should have made. You're not doing this because you're trying to aggregate data from all different sources, and you're not trying to big a massive data lake for people to use. What you're doing is saying there is a common issue that various different business stakeholders are involved in, and we want to solve this together. But right now we have so many data needs, and we do this individually on a point-to-point basis that it's generating too much overhead. So what we want to do is now unify that. And in many of the cases, it requires a little bit of governance and communication between the groups, but they're having these discussions anyway because they work together. So for example, we work with payers, and we need to understand things about our patients that they're providing member support to. We have that relationship already. It's just hasn't been kind of memorialized in a governance structure.
Right. Thank you for that. And we'll have time for one last question here from Kelsey. What is the architecture like? Do you use semantic layer for when your users are interacting with the hub? I think you touched on this a bit, but if you want to just rephrase what the architecture is like.
Yeah, so I think much of the data lands on a staging area, and then we build out different levels of or we cleanse it. So the first layer would be in the hub would be a staging area. The next stage would be just kind of cleaning up general things that are like null fields and duplicates and things like that, just making sure that the data is clean. And then the semantic layer really has to do with the question that was discussed before. What are the terms and definitions that people want to leverage to define, what someone going through a journey is, and
Mhm.
how do you put that into practice. And there's a lot of flexibility there. You could do more things more locally, but you can take advantage of common definitions across.
Awesome. Well, Alex, doesn't time fly when you're having fun? This is
Absolutely.
this is it for us, but I want to thank you again so much for helping kick off the Dedicated Healthcare Conference. Thank you so much for your time here and for taking the questions. And again, thanks for the audience for the great questions. Please keep those coming. It's so much fun to see what comes in from the live audience. Alex, I will see you online. And for those who are interested, find Alex on LinkedIn. Probably is that a good place to follow
Great
you and
place to
connect?
start. Yep.
Okay,
Thanks,
awesome.
Kate.
Thank you so much.
Thank you, everybody.
Okay. Before we introduce our next speaker, we do need to announce some winners for that dedicated circle giveaway. So I'm going to go ahead and get my screen shared up one more time just so we can remind you of what hashtag to use. It was hashtag dedicated to play. We're going to select 3 winners. We're going to select all 3 winners right now. So as I click draw, you can probably get your entries in. So I'm going to go ahead and start the first one. This is for the Dedicated Circle. So it is an online community/course platform where we have courses on data visualization, data storytelling, and dashboarding. And congratulations to our first winner, Brandon. Please follow up with me on LinkedIn to collect your winnings. So I'll let the dust settle. There we go. I'm gonna click draw again. We're gonna have our second winner. I see those entries are flying in fast. We will have more giveaways throughout the show, so make sure you stay tuned. Tony, congratulations. You are our second winner. Again, I'll let the confetti settle. Hopefully, you guys are having fun with this. Just send me a note on LinkedIn. I'll know I'm writing your names down. I'll know who you are, so I'll make sure to provide those giveaways. And gonna draw one last time for this specific giveaway. And our third winner is, drum roll. All right, Miguel. Awesome. I love it. Thank you so much for playing. I'm going to go ahead and introduce our next speaker in just a second. I'm checking in. I see lots of comments in here. I see folks are excited that they won. So I'm glad to see that. I will pull up our next speaker here. There we go. And share. All right. So our next speaker is Carrie Liu, and Carrie is currently the Director of Data Analytics at Haptia Analytics. She's a mathematician and data scientist with over 10 years of experience in the UK healthcare and life sciences sectors. She is dedicated, maybe she's dedicated, to helping her clients achieve business transformation through impactful, actionable insights and end-to-end consulting engagements. In 2019, Carrie established Haptia Analytics, which allows her to take on independent data science projects while also dedicating time to pro bono work and charitable causes. She believes that data and mathematics are essential for making better decisions and applies this philosophy to her planning and decision-making processes. Today, she's going to talk to us about using healthcare analytics skills to help charities, and I think that is such a great topic. I am super excited to welcome Carrie up on our virtual stage here. Welcome, Carrie.
Hi, everyone.
Hello, hello. I'm so glad to see you here. I'm going to give you the stage. I'll see you in about 10 minutes. And a reminder to the audience, jump in here with questions. We'll take those in about 10 minutes.
Okay, cool. So, hi, everyone. My name is Carrie, and I am from UK. So, it is lovely to meet you everywhere here. I'm really nervous because it's the first time ever I speak to the US conference. So forgive me if I'm being a little bit nervous and my accent and things like that. And first of all, thank you, Kate, for having me, and the other presenter who giving me some tips about this presentation. So to begin with, I would like to tell you a little bit about myself. Um, so if you ask me when I'm young, like when you're a student, they normally will ask you is like, what would you want to do when you grow up and things like that. To be frank, I have no idea. The only thing I know for sure is I really love mathematics, and also something that I really contribute to the world is through mathematics and numbers. And not until about in university, my grandma having a heart attack and what passed away during the moment that she going to the hospital. Actually, it was 20 years ago today, so I cannot really big moment and big hit to me today. It's very emotional. I If you ask me 20 years on now, do I still feel sad and stuff? I tell you, extremely sad, and also extremely. I still want to know what happened on that day. What happened to her? Is anyone helping her? What kind of service does she got? Just that kind of question I want to answer. So that is the reason why I always know that I want to work in the healthcare. And I was really fortunate. When I applied for jobs after I graduated from university, I worked in a national health service in the UK. So NHS is a really big thing in UK, and compared to US, it's different. Is because NHS is a publicly funded healthcare system, and they provide all the medical care, including surgery and consultation, everything. So all is free for all the residents in the UK. So meaning that a lot of medical treatment is not coming from the payer, the user pocket. At the same time, people don't normally talk about insurance that much either, so we don't really think about that. Last thing is because the public funding, so that is why everything is go through government. So there is a lot of things that we can learn from it. I working for NHS for 13 years in different department because I want to learn something, and it was a great time for me. Is where being an analyst in there, you looking at the data, how government and using it, and what you can do about it is mind opening. I left about 5 years ago. Because I got an opportunity to work for a US company called at that moment of time called IMS Health, and now it's called IQVIA. I don't know how many you heard about them. So what I find it really interesting and funny is they are using exactly the same data when I'm working in the NHS, and they are providing this consultancy service back to the NHS and also pharmaceutical company and research center, which is something that I never dream of and work about. So for that, I kind of like understanding. Oh, okay, so not just about the service that we're providing, but at the same time, it's about what we can do with the data in different sectors. So that is a big thing for me. So, and then after that, about 2019, I kind of at that kind of career moment, I'm like, okay, I don't want to be a CEO in the company. I don't want to be a director in the company. It's not that I don't think I'm not capable of. It's just not something that I'm passionate about. And at that moment of time, I just thought, why didn't I just step back and then do some freelancing work and see whether what is it bring me to? So that is at the same time is I contact a lot of different charity to see whether what kind of skill set that they need from me, and also what can we do together. So for that, I'm normally do about 60% of the time I'm working for like client. I will call him client, like anyone that who want to do healthcare analytics, I will work for them. And then 40% of the time will be different charity work. So one of the charity that I'm really working with a lot is called Age UK. I'm the trustee in with them. And the reason why I working with them is I split it into three different part. So like I say, Age UK, as you can tell, they are service for their population will be more older. But as many government, they normally do things when things happen instead of prevention. So they are looking at the population that is sicker, and also like they don't may not know how to get help, and also they need help as well. So I brought in because I thought data is everywhere, because under the law, NHS need to publish a lot of data that they got. So that is why I think I got the expertise to come in to help them that what kind of data they can do, they can help, and what they can do with it. Because even though publicly available, if you don't understand the system or how the data have been collected, why they're collecting things, you won't be able to interpret the data correctly. So I think that is something we can learn as a data scientist. Is like, yes, we got data, but at the same time, you understand why that data collection exists at the very beginning, to understand why we can and what we can do and the limitation about it. So that is the first thing. The second part, I would say that because of the senior management, I mean, to be honest, they funding is very important, and also how they looking at their resource more effectively and achieve their goal. That is very, very important thing. So for me, working in the government organization before for so long time, I understand when you're asking for funding, how can you ask for it, and also how you write your proposal and things like that. So that is the reason why I work with them in more strategic level and understand how we can present the matter in more data driven way, because at the moment everyone will say that why are you doing certain thing, but because we need evidence, and data is a really good evidence there. And last but not least is s- volunteer. So a lot of charity that we're working with is the people that who come from volunteering. So what I mean by that is normally they do not take any money to providing the service or working. Even though they sometimes they do, it's really minimal. So it's unlike when you're in the corporate setting that you got some money, you got a market rate, you can ask for data scientists coming in to do the data. You cannot, because the staff that you got in front of you is what you got, and also most of them is not really data driven, and sometimes they don't even like number or afraid of mathematics. So my job is not only to teach them how to do like s- data science. It's like really basic thing like how to use Excel spreadsheet, how to do basic calculation to get the number. For example, basic thing like how many volunteer we got certain skill, how do we put that into a database. That is something that are helping them to set up, and also how to use it in more daily life. And from the previous speaker, Alex talked about like how to do dashboard and how to using it more, yeah, how to use data more correctly. That is something that are helping them as well. So that is the one of the charity that I'm helping with. Another thing I'm really passionate about is women health. So NHS is something really amazing, but a lot of service that is not included. So some of the stuff like women health, for example, recently we talk about menopause, and also like people would like to have a frozen egg, but frozen egg is not something that they think is medically you needed, so that is why it's not funded. But by looking at the openly publicly available data, we can find out that how many people would like to have that kind of information. And also we can talk to the organization that I'm working with, is a charity that who want to start that conversation going, to let the lady to think about it in the earlier stage when they can do something about it instead of being too late that in life. So that is another thing that I'm helping. It is about using the data that we got to make sure that people, other people, not just me, but like organization or things that can be helpful. So, and the last but not least thing is when I work in Age UK, and we also take on some volunteer as well. And some of the volunteer can become from university. So I have one university student using some of the data that we got in Age UK to do like dissertation for his master degree. So I think another thing like that would be quite helpful, because when you don't have a lot of experience, you want to help, you want to demonstrate that you got the skill. Helping charity is something that you can do, because they really appreciate that your input, and also a really new fresh mindset is amazing. So that is why I enjoy doing charity work a lot. And yeah, and here I am. I'm not perfect, but I'm still kind of trying to figure out what is the good better way to moving forward. If you got any suggestion or would like to let me know, then feel free to contact me.
Awesome. Well, Carrie, thank you so much for the talk here today. I really appreciate you taking the time. And I do have some questions for you. I think this is such a great topic. Anything we can do to make a difference and make a positive impact in the world, we should obviously be doing, especially if we've got the skill sets that are in demand and can actually help make a difference. We had a completely off-topic question about which stuffed animal you were holding in the beginning. Was it a cat or a koala? You had some.
No, it's a it's a dog. Because it's in London it's snowing at the moment, so I'm really cold. I don't want to use a hot water bottle, so that is why I use a microwavable teddy to keep me warm.
That's adorable. I love it. Thank you. Thank you for sharing that. So the question I had was, for those in the audience who want to get started, what advice would you have for them? Let's say they're also interested in using their skills for helping a charity, and maybe they're looking at this as a way to just be a good member of society, but also as a way to maybe get some skills so they can be more valuable in an organization. How would you recommend they get started?
So I think if you come from a more junior like university student, or you just start off, or you just just not less skillful. I would say that.
Mhm.
I would say data kind or data UK, and there is a lot of charity that doing like a lot of data challenging things that they for data for good. So you can join them because some of them will be like individual project that you can do, or some of them that you can be like more like competition type, because even though they're using the data set for competition, but at the end the outcome or insight that you get,
Mhm.
they will provide it back to them. So that and another thing. The other thing I was saying is, if you talk to the local charity, you will be surprised how many of them. So if you would say, for example, for healthcare point of view, food bank is something that is very important, because the thing is, if they haven't got enough food,
Yeah.
they become lack nutrition, and then become they need to use the health service. So one of the first organization that I go to is food bank during the COVID-19 situation,
Mm.
because I want to find out is like how much money, for example, if I got $30 per week, how can I survive with a nutrition service? And also find out that another thing I find it really funny is, for food bank, for example, you want to look at the demographic, like the family that who coming in, why they are coming in, because sometimes that is not just them having a problem. People
Mhm.
from more like a gentleman, for example, that single gentleman that who live on his own, may not able to come forward because it's the pride that they got. That is another inequality thing. So things like that is really good to feed them back. And also from a data, you can look at like people, elderly people living in, then you can get that information to the local charity, saying that I think based on the data that we got, this area that you should focusing on, because they haven't got enough service or things that can be which out they can do. So I would say that is that. Another thing that I would say, if you become more mid-level or more senior people, you can talk to your company to do more like charity work that and more data intuitive. It
Mhm.
could be, for example, like I recently helping a charity deliver a data science school for girls that who age 15 to 17. That is like
Mhm.
4 classes every single Saturday for the student that who from lower background income, because sometimes learning skill is quite expensive. But the thing is, things like this, as a mid-level, you can find out a way that your company can help them as well. So
Yeah.
it not may not be healthcare related, but at the same time you can upset your skill and also promoting your company. That because from a
Mm.
healthcare perspective, a lot of people didn't realize that data can help do so much about it. And especially public perception about it is, or I only do certain thing. I'm not a doctor. I'm not a nurse. How can I help? I
Right.
think being a company that consultancy company or pharmaceutical company, you can talk to them to see whether how you're using math, and give them a more like perspective why that is good as well.
Yeah. Absolutely. So we have a comment here and then a question. So first, a comment here from Claudia. She says, thank you so much for your talk, Carrie. I work for NHS and starting in data analytics, and every day I see how much data we have that could be used for good. And I'm glad that you're actually finding ways to go ahead and use that. And there was a question here around sort of what are the sort of skill sets. So here, Aditya was asking, how do we actually enter in the healthcare industry as a data analyst? I think one way to bridge that question with the charity work is, are there some common skills that are in demand in data analytics healthcare where folks can learn those skills and then start going to charities to help the world and build those skill sets?
Hmm. So for me, it's like we got NHS, but at the same time, if you think about, I know a lot of people didn't think that insurance is another way that you can go into as a healthcare company,
Mm. Okay.
because insurance is something that they're looking at how to make sure that you are looking after yourself. They want to insure people that is healthy. So it's kind of the flip side is, from an NHS point of view, we're looking after sick people. From the insurance point of view, they're looking for more healthy people to become their client, because they
Mhm.
won't be losing money. So that is one thing that I think in America is a lot better than us in UK. Is insurance company definitely one of the things that you never think of, but they can help. Secondly is another company type of company, I would say that health Fitbit type of apps type of company
Mhm.
startup, things like that will help you as well, because the thing is they want to make you healthier. So that is what kind of linked to the promote and prevention of the healthcare service that you need to provide. So that is another thing. The startup is be another thing that I think, if you never a big company, or it's not your cup of tea, Startup is somewhere that I think you can be more creative on what you're trying to do.
Right. Okay. I love it. Absolutely. Well, Carrie, I want to thank you for your time. We've got some feedback here that people really enjoyed the presentation, and I really, I value your time here with us today. And thank you so much. I know time is really flying. Every time I feel like we start a conversation, I'm like, okay, time for the next speaker. So this goes to the point of this is lightning fast, rapid fire conversations, and hopefully the audience is learning a lot and getting a glimpse into all these different aspects of how data is used in healthcare. Connect with Carrie Liu on LinkedIn, and make sure you follow up. I'll drop your LinkedIn profile into the chat so folks can connect with you more easily. All right.
Definitely. Thank you so much. Bye.
Okay. Thank you, Carrie. All right. So we're going to go ahead and introduce our next speaker. I'm going to bring up Stephanie here in just a second. So Stephanie is a Health Lab Vice President of Analytics at RS21, an Inc. 5000 fastest growing data science company, enabling faster, smarter, better decision making with data and AI. Stephanie works with healthcare leaders to access insights from complex data and visualize and improve health, including financial, performance, and population health. As a leader of RS21's Health Lab, she oversees product and services delivery of data analytics tools and ensures clients can derive insights from their healthcare technology systems. Formerly, Stephanie held analytics and technical roles at healthcare organizations, including Blue Cross Blue Shield of New Mexico and Presbyterian Healthcare Services, before co-founding her own healthcare analytics and business intelligence startup, which was acquired by RS21 in 2021 to form the Health Lab division. She is a strong advocate for open collaboration, data literacy, and women and minorities in STEM. All right, I'm going to go ahead and bring Stephanie up on our screen here. Hello, Stephanie. Welcome to
Hi.
the Health Conference.
Thank you. Can you hear me okay?
I can hear you. I can see you. Brilliant. I love this. You have such a strong, powerful background. And I just realized acquired by RS21 in 2021. I'm like, look, it was meant to be.
Oh, hey. There you go.
All right, so I will hop off the virtual stage gently, and then I'll be back in about 10 minutes with questions.
All right, let's do it. Well, hi, everybody. I'm Stephanie Garadia, a lover of data and healthcare subject matter expert. Today, I'm here to talk about new and novel uses of data in healthcare that you can start using to take your health data game to the next level. And I'll give you 3 actionable tips or recommendations on how you can get started. But first, a little bit about me. I have dedicated my career to health data. I have over a decade of what I call in the trenches, health analytics experience that spans the entire healthcare ecosystem, from payers and health insurance companies to care delivery, hospitals, health systems, to technology vendors, to startups, to health information exchange and government programs, really the entire value chain. All of that did lead to co-founding a small healthcare analytics startup in 2017, which was acquired by a big data science and data engineering firm, RS21, in 2021, where I now lead the design and delivery of health and community data solutions as the vice president of the Health Lab. So I've been in data, and I can tell you that more data is being generated today than ever before, but we are generally only looking at a sliver of it. So I'm not here to tell you that we need more data, but I am here to tell you how you can start getting more from your data now. So here are my 3 tips or recommendations on how to get new and novel methods of data and data science into healthcare. So the first is doubling down on what I like to call data outside of your 4 walls. So COVID-19 caused a real paradigm shift in a number of ways. It exposed gaps in our current data systems, and it exposed the need that we understand and, most importantly, share data across silos. So think about this. You generally only have access to the data that occurred within your proverbial 4 walls. That could be your organization. That could be your software system and your client base. That could be your health system. That could be your community. 4 walls is a little bit of a metaphor, but generally we have access to our internal data only. Maybe some partnerships if we're lucky. But when you really look at it and you just have that internal data, you see that there's some very big gaps in that story that remains that can help paint the picture of into your analysis. And that's data that I often refer to as external or outside of your four walls. So by only looking at data that you have access to internally, you miss a big portion of the rest of the picture. So for those of you who are already in healthcare, you may know some of these concepts as social determinants of health, which are colloquially spoken about as basically external determinants or risk factors that can explain up to 80% of a person's health outcomes and behaviors depend on factors and data that's completely outside of the health system, outside of the four walls. But it's also so much more than that. It's what's going on in the economy, what's going on within neighborhoods, within the policy, at other health systems, and et cetera. So we'll take telehealth or virtual care adoption as an example. Say we know what our internal data says. We can ID where patients have used it, which patients have used it, for which conditions, how often, so on and so forth. But if we started to bring in data from outside of our four walls, we might also be able to start understanding, are we getting to the areas that have the largest health disparities in the region, regardless of if there are patients or not? What's the primary language in those neighborhoods? How does it compare to our patient population or our patient mix? Where's the closest specialist, behavioral health or otherwise, in or outside of our own network? What does broadband coverage look like in those areas? Is there some other underlying reason where people were not using telehealth or virtual care, where we see certain blackout areas? There's so many, 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 many more use cases. After this webinar, if you follow me on LinkedIn, I will share some example data sets that could get you started. But for now, to action on this recommendation, start thinking about what other data would I need from outside of my four walls to help complete this story. My second tip is to start considering even less traditional data sources. These tend to be proprietary for purchase or otherwise exclusively obtainable through research and things like that. As an example, one of the things that we've been working on at RS21 is using anonymized cell phone pattern data to understand how and where people move throughout their communities. This is very powerful data when you merge it with some of the other types of data that I was just talking about. So I'll give you an actionable use case. One of our clients got a CDC grant to improve vaccination rates in Laredo, Texas. So they wanted to do pop-up vaccination clinics to reach residents in Laredo who had the highest need or at the highest risk, and they needed to know where to go. So they came to us. Now, if you might think, okay, well, we'll map out all of the high-risk neighborhoods on a map and see where all the largest health disparities are, which we did. But when you look at Laredo on a map of at-risk neighborhoods, the entire region along the entire border lights up. And resources are very finite, and you can't quite go door to door across all of the most vulnerable communities. So we were then able to use that data and overlay on top of that our cell phone movement pattern data and combine it with some geospatial analysis to really understand exactly where any resident who lived in those high-risk neighborhoods tended to travel the most. Where were the hotspots or the high-density areas of traversing through the region? When and why did they visit different areas by day and time, so that the clinicians knew exactly how much traffic to expect, how many doses that they needed, and that they could deploy into a highly accessible location. So from all of this analysis and all of these different types of data sources, we were able to recommend 3 specific locations to deploy those pop-up clinics down to the street corner, and we were able to recommend the best time of day window. So that's just one example of lots of unique different types of data sources that are out there like this and like others that can help paint a picture about patterns, behaviors, and decisions. This goes beyond data outside your 4 walls. It really depends on what you're going for, but we start getting into things like social media data, purchase patterns, benchmark data. There's even data brokers out there now who can collect data directly from individuals, compensate them, and then make that data available to you or to commercial entities for purchase. Things like that are out there. And there's a lot of different things we can get from combining this type of data with some of the other types of data that I mentioned, as well as your own internal data, of course. I like to think of this concept in the context of what other data would I need to tell me something I don't already know or suspect? And that's how it tips me off to if this data is one of those kind of proprietary or more novel use cases. And finally, my third and last recommendation about getting new and novel methods into healthcare is to start thinking about data science methods that can be brought into healthcare from other fields, like specifically research and development or R&D or manufacturing, for instance. We see this a lot. We see even methods from healthcare being brought out into other fields and vice versa. But I think we need to start thinking more about how to bring methods that are commonly used in other industries into healthcare. One immediate example that comes to mind and is very interesting to me, my husband is a satellite engineer. I think it's a method that's grossly underutilized in healthcare, coming from the world of engineering, called modeling and simulation. That's a big umbrella term. But basically, modeling and simulation is where you can mathematically model or replicate complex scenarios, visualize dependencies, test the impact, or simulate a likely outcome of an intervention or of a program before they're deployed. At RS21, we see this a lot in space and satellite work, among many other areas where modeling and simulation is applicable. But for healthcare, this type of method could be predicting and visualizing the what ifs, and there's a lot of what ifs in healthcare. What could happen if I pull on this lever, or deploy this kind of intervention, or reduce reimbursement by this much, so on and so forth? What level of impact can I expect to have? What's the scenario that has the highest chance of the return on investment or best chance for impacting outcomes? What could the trade-off cost be? We could really model and simulate out a lot of different scenarios, programs before we deploy them, changes to contracts before we make them, and help make much more informed decisions and trade-off decisions from that. If you're looking for an easy place to start in modeling and simulation, or M&S, one method that I think is for data scientists would be very easy to start in is discrete optimization. It's a linear programming method that allows you to model constraints and parameters of different scenarios using whole numbers and linear algebra. And it helps to identify the best or the optimized outcome as you tweak on different input variables, and you can model out constraints and things like that. So I could go on and on here. Like I said, lover of data, lover of healthcare, lots of other data scientists, data science methods, AI, ML, NLP. I didn't even touch on that. But the point here that I'm trying to make is that there's so much untapped potential from the data that we already have at our fingertips right now. So no, we don't need more data, but we do just need to start getting more from it. And I think we're on the right path, but we're going to need to put our brains together to take it to the next level, especially as so much of this is dependent on data sharing and idea sharing across silos, across entities, across organizations. That's the future of health. And that's also the future of healthcare and data. So rising tides lift all boats. So if you're interested in more concepts like this, follow me on LinkedIn and Medium. I write articles and resources related to healthcare analytics and topics like this.
Awesome. Thank you so much, Stephanie. Did I hear you say we don't need more data?
I know. As an analyst, it hurts me, but there's a lot of data out there.
We want
all the
data.
data.
I get it. I love the talk. Thank you so much. So lots of questions coming in. I'll start with my own question. So you started the talk by saying we need to look outside of the four walls, and you mentioned a couple of sources, but I wanted to ask, how do we know what we need outside of those four walls, and what are some of the best methods of actually getting that data? That's sort of part A. And part B is trusting that data, because if it's not within our four walls, we don't really know about the data quality.
Yeah, I think that's any analyst problem for anything, probably. But I like to start by, you're obviously going to start with your analysis, and it's going to raise a lot of questions. I like to start by really thinking about, what else do I need to know about this that I don't know? What are my blinders or my biases or my blind spots here? And that starts to help me tip me off to some areas. For instance, if I'm doing an analysis on a population of mine and I'm making conclusions, I might go, well, wait a minute, but what's the overall health composition look like in that region? That's something I can't see from just my data. And then that kind of tips me off to where or what I might look for. Government sources are a really good source. Many of you probably already use, census or CDC data, things like that. There's a lot of other really great, robust, like CMS puts out a ton of great healthcare data that could be used, and is reliability is a whole other topic that we could get into another talk about. But I'd probably start there. Yeah, and we get into a whole nother ball of wax when we start talking about getting it from other contributors and things, but I think that goes a little along with cleanliness and quality.
Okay, all right. So Jorge had a question here, well, more of a comment, but healthcare data is so special, kind of personal asset, and can be shared freely. So wanted to get your thoughts, especially on, I think you mentioned the location data and making sure that you set up those tents or those on-site clinics. and tracking locations and where people actually go. How do you work with, I guess, the government or the regulations to make sure you're not breaking any rules there?
Right. I would say aggregates are your friend,
Mhm.
and anonymization, especially in the case of the cell phone pattern data. My company is a very highly ethical data for good company, and so we put a lot of privacy parameters around how that data is used. Again, that's a whole other topic I could talk about for hours probably. But in healthcare in general, yeah, HIPAA is a huge red tape issue. The way that has been the most beneficial for me, especially on these population type studies, community type studies, is aggregating averages. It's not perfect, it's not
Yeah.
down to the person, but it can help you get some directional pointers.
Absolutely. Thank you for that. All right, there was a question here from John. He's asking, how would you consistently link data semantically, both internally and externally?
Ooh, that's a tough question. The best methods that we have right now, we're doing a lot of geospatial analysis. So a lot of our things are linked on geospatial granularities. It's not a perfect answer. Again, it's going to really depend if you're going, belly button to belly button. That's a whole other different situation. If you have master index, master patient indexes and things like that. Again, because I'm kind of saying get started with some aggregates. I think and geospatial tends to be the common denominator right now until we can figure out a little bit of a better way to consistently link, but there's no universal identifier, unfortunately. Happy to talk again more offline about that. I love this stuff.
Awesome, thank you. And I guess one last question that I had was, how did you even come up with sort of this topic? The fact that we need to be innovative. I think a lot of data analysts and folks who work in this space, they tend to focus on within the four walls, right? We have so much data here we need to deal with. What made you want to explore and had this idea, of looking outside and beyond the data that you already have access to?
Well, I am an analyst by practice, and so naturally I want all of the data about everything so that I can answer all of the questions that I may have.
Yeah.
So I think that started it. But I also think that, we're not seeing the impact in healthcare. We're not seeing the change. We're not seeing the cost reduction, the improvement in health outcomes. And I think it's a natural progression of where we're going. A lot of health systems and payers and things like that, well, we're trying, or we already have done a lot of the low-hanging fruit that we can get at internally. And so I think people are starting to look externally, as well as starting to really understand that health is a whole person, whole community ecosystem. There's lots of vendors in the space. There's lots of systems that all put together paint even just one person's picture or story through the healthcare system. So I think it's just a natural progression of where things are going.
Okay, well, awesome. Thank you so much for your time here today, Stephanie. As Stephanie mentioned, she's on LinkedIn, she's on Medium. Go find her in both places, subscribe, follow, and I guess follow up and make sure that you guys connect with Stephanie to continue this conversation.
Sounds great. Thanks for having me, Kate.
Awesome. Thank you. All right, we're going to go ahead and keep this data party moving. I'm going to introduce our next speaker here, Paul Bowl. He's going to talk to us about healthcare price transparency. Paul is the Vice President of the Data Analytics Practice at Amitech Solutions. It's a healthcare data analytics and automation consulting firm. He's been a healthcare data and analytics practitioner for 25 years, working on everything from data governance and organizational change management, to data warehousing, to advanced analytics with machine learning. Paul is also an adjunct professor at St. Louis University, teaching graduate students in both the healthcare data science program and computer science department. If you see a Missouri license plate with 0 Data 1 on it, that will be Paul, which is actually hilarious because I recently got a new car and I wanted to get custom plates and I wanted like dash data dash. I still have to go ahead to the New Jersey DMV and actually make that happen. But Paul, you and I might have similar license plate. Hey, Paul, welcome to the DATAcated show.
Thanks so much, Kate. Yeah, that'd be great. We can park next to each other and be twins, right?
You'd have to drive up here. I don't drive that much. So.
That's okay. I don't mind.
Awesome. Well, Paul, thank you so much. I'm gonna give you the 10 minutes and then I'll be back for some questions.
All right. Thanks, Kate. I want to thank Stephanie, especially for setting up this conversation really nicely. The topic I'm going to talk about is an example of another external data source that is not really core to, for instance, what hospitals use on a day-to-day basis, thinking about how do they treat patients, how do they run their operations. One of the topic we're going to talk about here is price transparency in healthcare, and a lot of you, I assume, are folks who already know something about what's going on in healthcare. But for anybody who doesn't know what's going on specifically with price transparency, there was a movement that started several years ago with this idea that if we gave people more information about how much healthcare really costs, then we'd be able to use economic levers to start to bend the curve or flatten the curve of increasing healthcare costs. If you look at the statistics, we continue to show healthcare costs being an increasingly large portion of all of our budgets on a year-to-year basis. We see in the inflation rate of healthcare always exceeding the sort of the overall inflation rate. The costs just keep going up and up. We have not been able to bend the curve there. The theory is that if we let people know what they're going to pay for healthcare services, then maybe they'll start making more rational choices, financially, economically rational choices. And that was really part of the foundation of, I think, how people talked about this initially and why they were thinking, hey, we should make what are you going to spend more readily available. But the problem with that sort of thinking process is that it assumes that we're all rational decision makers, which I think, we all know we're not, right? We know that behavioral economics comes into play here. We're not rational econs. We're humans that are making decisions about our healthcare. As human individual consumers, we think about who are the doctors that I know, who do my friends trust, things like that. But nevertheless, so we'll get into why healthcare price transparency is still potentially a really good thing. But I want to give you just sort of the timeline here, a little bit of background on what's been going on in healthcare price transparency. So pre-2021, there were some regulations that came out from CMS that said we want all the hospitals to start publishing their standard charges. Great, thank you so much. Now we know what hospitals, quote, charge for their services. But I think anybody in healthcare knows that those charges have very little to do with what ever gets paid by anybody to anybody. So that wasn't very useful information. In January of 2021, hospitals had to start posting their negotiated rates for services. This was a lot of big pushback from the hospital associations. Most hospitals didn't like this idea. I think that for hospitals, the idea of price transparency is a fear, a concern that insurance companies and employers, those people that they negotiate with, are going to use this as an opportunity to just push prices down. It'll be a race to the bottom, and hospitals will have an even harder time dealing with their financial challenges that they say they have, that they believe they have. Then in July of 2022, so just this last year in July, the CMS regulated that insurance companies, the carriers, had to start posting their negotiated rates as well. So this feels like a good thing, right? Now we're getting all this information out there about what it costs, what's being paid, what are the rates being paid for all the services going on back and forth within healthcare. What does this insurance company, what does this Blue Cross Blue Shield plan pay for that particular type of surgery versus what does United pay versus what Cigna and Anthem and Humana pay? This should be good competitive information. If you think about how this has affected other industries, we've seen a lot of cost control or price control in other industries because now we have really easy, ready access to what consumer goods cost. I can go on the internet and I can look up really quickly and get a whole range of prices for anything I want to buy from more of a consumer perspective, right? I want to go buy a new TV. I can easily find out what are the range of prices I might pay for that. So challenges that we've had with price transparency. Hospitals didn't like it in 2021. Initially, very few were compliant. There were, even by the end of 2021, there were at most maybe 35% of hospitals compliant with it. CMS didn't want to push the message, push very hard on compliance. They started issuing warnings. They still have yet to issue any really major fines that have impacted anybody. They did increase the fines. They really want this information out there. The challenge in terms of those of us in the industry who are trying to use this data for anything, of course, there are data quality challenges, and I'm sure there'll be questions about that. But to begin with, the hospitals had no standard for how they would publish this data. So the data was in a whole bunch of different formats, not just technically the format of the files, but also semantically. What data did they include? How much detail? What attributes? What coding sets did they use? All very, very hard to understand. Now, in 2022, when payers started releasing their data, at least they had some standards. CMS came up with an open standard, what they want the payers to publish. There's still some variations within that, but at least it looks a little bit more standard. There's still lots of questions about data quality, the accuracy of the information. And the big challenge with the payer data has been that these are literally hundreds of thousands of data files because there's so much variation in negotiations and how the plans are structured, and each individual contracted rate with any one hospital or any one individual doctor. So they're huge files, literally hundreds of thousands of files from some of the across all the carriers, and many terabytes of data, because these are just enormous files. I'm talking about millions of providers across the US, times hundreds of thousands of different procedures they might provide, times hundreds of different plans that the insurance companies have. So we're talking about really large data sets. So we've got lots of data, we've got lots of challenges, but in theory, we have huge potential, right? Because we do have a real issue with the increasing cost of healthcare, and we really have to do something. And you can imagine that being able to expose that information and use it effectively is going to be something that should be able to bend the curve for us. The key point, though, is that the audience for this information, we shouldn't be talking about individual consumers, you and me as patients, because we are not the primary buyers of healthcare services. We're the consumers of them, right? We receive the healthcare services from doctors, from nurses, from therapists, but we're not typically, in most cases, the primary buyer. The primary buyer is our employer, who provides us with insurance, and they are the insurance companies who negotiate those rates with the hospital systems and with large medical groups and things like that. So when we think about what can this data actually be used for, then we want to look at the ways that, say, like a hospital system could potentially use this data. Kate, can we pull up my slide? Thank you. So this is a lot of stuff blurred out here, but this is just one way of looking at how do we actually use this data to get a good picture of what's going on in a particular market. This is some work we did for a large hospital system. What they were interested in, they were going into negotiations with one of their insurance companies, one of the major insurance companies they work with, and they know how much they're getting reimbursed for certain services. And in this case, we're looking at a chart that's focused on inpatient acute services. So a set of roughly 700 different services that a hospital would provide, typically surgeries or inpatient stays. And what they wanted to know is, with this carrier, what does the price transparency data say about their reimbursement level versus the other hospitals in the region? So these are color-coded by the different hospital systems. Each bubble is an individual hospital. And what we're showing is the reimbursement rate of each hospital relative to the average within that market. So this is narrowly focused on a particular state, and even broken down into some smaller markets within that. And what is the overall average, weighted average reimbursement rate for inpatient services at this hospital compared to the average in the market? Historically, people have done a lot of benchmarking using CMS rates and things like that, and that's fine and good. But if most of your business is commercial, if a large portion of your business is commercial, it's more useful to focus on the relative rates within the market, kind of leave CMS reimbursement out of this. And what this shows as a trend, you see the blue dots here that are filled in. You've got a hospital system that a large number of their hospitals are well above that line. You can see a huge variation, of course, anywhere between being paid 70% of average up to 140% of average. And again, these are weighted averages across all the services, weighted based on the frequency of that particular service. So obviously, You don't care as much about price differences in a brain surgery that you might do 10 times a year versus a hip surgery that you do 10,000 times a year, right? So the differences are weighted based on the procedure volume. So when you start thinking about the ability to look at data this way from in more of a bulk format and think about the whole negotiation that you as a hospital do, or as an insurance carrier needs to do with multiple different hospitals, understanding your position at a particular major hospital in a region relative to the other carriers, or as a large self-funded employer who's thinking about how do I negotiate and manage my rates, manage my healthcare costs, then this kind of price transparency data brings a whole new lens to it. It allows you to do some of those things that Stephanie was kind of talking about, some of the simulations and the models and the what if analysis. You could think about, what if I reduced my rates in this area by a particular amount, or if I increase reimbursement in one area because I know that maybe the market's going to change based on how patients are aging or how the demographics of that market are changing. You can see, in combination with other information, the price transparency data that we're now getting access to in healthcare really opens up a whole lot of new doors for understanding the economics of healthcare, and I think really being able to bend that curve more significantly than we have been able to in the past. So another new great tool in terms of healthcare data. So I'm really excited about it. I've been doing quite a bit of work in this area for the last couple of years. And if you're interested in any more of that, you can find me on LinkedIn as well. You'll see I post some things there on a regular basis. And I'd love to have folks reach out to me and have more conversation about this. So thanks, Kate.
Kate is right here, I promise. Just doing a million things in the background. Hi, Paul. Thank you so much for that awesome presentation. I have so many questions. I'll start with this. So at first they released, and by they I mean the hospitals, they had to release the actual charges, right? Then they had to release the negotiated rates. And my first question is, what was the disparity on that? Like how far off were the actual versus the negotiated rates?
Well, I mean, they're not even comparable, really, and it can vary so much from one procedure to the next. I mean, think about it like, well, I don't know. I mean, for the last few years, there's been a lot less negotiation, say, in automobile purchases, right? Because the market's been the way it has. But we're talking about disparities of more than 50%. So you might say, hey, we charge $7,000 for this procedure, and really the negotiated rate is $2,500. I mean, it can be really, really ridiculous. And even the negotiated rates between different insurance companies can be that dramatic as well.
Wow, my goodness. Very, very interesting. And we've got questions coming in from the audience here as well. So I'll start with Nicole. She says, Paul, what impact will this have on rural hospitals, which have been increasingly closing their doors because they're financially in the red?
Yeah, I think so rural hospitals are an important one. There's a great book out there if you want to read something really depressing. It's called The Hospital. It's an investigative report book. It's really good. And it takes place in a hospital in Bryan, Ohio, a really small hospital there. The challenge for a lot of small hospitals, I think, is that they lack some of the specialties and expertise. They lack the economies of scale, things like that. So I think that one of the things we can, with price transparency, one of the things we can do is paint a picture. So if I'm a hospital, small rural hospital, I can paint a picture for my negotiations when I go talk to carriers, when I go talk to maybe a local rural employer who might be, fairly large part of my population of patients. We can talk about, here are the services that it makes sense for us to provide here. Here are the services where we transfer folks. And we need to make sure that, yes, we know that you could get this particular service much less expensively at a hospital 60 miles away. But one of the things you have to pay for is the convenience of having us here more locally to you. And I think having those rational discussions, I think that can make a big difference, rather than just having it being a blind, cost conversation.
Right. Absolutely. That makes sense. Thanks for sharing that. Question here from John. How does prior authorization factor into your statement that patients are not buyers, but consumers? If my insurer won't cover my costs, don't I have to cover them some other way?
Yeah, that's a good question. Prior auth is really a whole nother, whole nother ball of wax in healthcare. Um, what I would say is that there's some classes of services, there's some categories of services that are more elective, right? Things
Hmm.
that you can choose to do, and in those cases, absolutely, you're going to have more flexibility to shop around and decide where you want to receive those services. In those cases, one of the things we're seeing is we see the emergence of specialty benefit managers. So, just as an example, in the treatment of infertility, so fertility specialists, there are a number of companies out there that specialize in contracting fertility services specifically, and they'll build a carve out for from United or from another large carrier. They'll carve out those services that might not otherwise be fully covered by that carrier, and you as an employer could purchase that extra benefit for your employees, right? And in that case, you've got price transparency coming into play to help
Hmm.
understand what is the going rate when it's authorized. How can we provide value add services as that carve out carrier, and then me as an individual consumer, then I can make decisions about, I know that this particular type of service is not going to be covered. Do I buy alternative insurance to help cover the gap, or do I pay for it out of pocket? And then again, having access to those cash prices is really helpful. So
Yeah.
yes, in some cases, but that's not the majority of healthcare spend.
This whole area is just such a mess. It's honestly, it is so sad and depressing. But I am glad that you're bringing light to it. I actually till this day I didn't know there was an act where people, companies had to disclose those rates. So I think we're moving in the right direction. There's a question here from George. He's asking if COVID threw some of these analytics out of whack. I'm going to assume yes, but I'll let you answer.
Yeah, I would say probably. I mean, so we were the hospitals were I used to work for a hospital system. I think hospitals are generally really great organizations to work for, but I
Mhm.
think in general, on the whole, they were woefully underprepared to have this conversation about price transparency and share with the world what their negotiated rates were, because I don't think that they had for themselves a good handle on that data to begin with. I mean, some did, of course, but I think most hospitals don't have a great handle on that data to begin with. So when they were being told, "Hey, get ready for this in 2020, going
Mhm.
into 2021 compliance," and then they get hit with COVID, of course, it's going to take a backseat. And so I think that's a major reason that in 2021 we saw a lot of the hospitals out of compliance.
Mhm.
They didn't, first of all, they didn't want to comply, a lot of them, but they also didn't have the prep time, really. They couldn't dedicate any time in 2020 to get their data in order and do a significant project to pull that together and make it easy to use.
Right. Thank you. And I'll end with one final question for you. It's about what good looks like. So we know we are potentially moving in the right direction, but what's the end goal? What does good look like for price transparency in hospitals?
For me, I think that good starts to look like when we can really see a bend to a flattening of the rate increases, right? So we continue to
Mhm.
see rate increases faster than the growth of the economy, and increasing spend out of our own individual budgets when you take into account premiums as well as out-of-pocket expenses. As soon as we see two things happen: one, that cost curve start to flatten, so we're not,
Mhm.
it becomes a smaller portion of our wallet, and also that I think I don't think it'll just happen where we start rationing healthcare and we really start forgoing services. So I don't think I don't think we'll let quality take a big hit. So we'll see quality continue to advance because technology is going to help us do that, but we'll see a flattening of the curve. That would be the ultimate outcome.
Awesome. Well, Paul, thank you so much for taking the time to talk to us today. Thank you for your presentation, for imparting your knowledge on us, and really making, at least me, I'm assuming most of the audience as well, making us really think about this topic. So I really appreciate your time here, and thank you for the audience for the great questions. Paul, where can folks go to follow you, continue this conversation?
I'm
Is
easy
it
to find on LinkedIn. I'm pretty much the only Paul Bull out there, so I'm easy to find and happy to connect with everybody.
Awesome. Thank you so much. All right. before we bring on our next speaker, just a quick note here. We have one more giveaway for the DATAcated Health Conference. We have partnered with Avery Smith from Data Career Jumpstart, and he's giving away one free bootcamp for Data Career Jumpstart. It's truly awesome. Go check it out. I'll put links in the chat, but hashtag bootcamp to play. It's basically an online data bootcamp. It's 100% project-based. I think that's the only one out there that is fully project-based. And it goes beyond teaching skills like Excel, SQL, and Tableau. It also teaches you how to build your own project portfolio, grow your network, and how to land a job in data, which I think most people would want as a result of the bootcamp. It's valued at $2,000, and today we're giving away one free access to that bootcamp. So just type in hashtag bootcamp to play, and we'll pick a winner right after our next speaker. All right, speaking of our next speaker, I'm going to go ahead and introduce you to Alyssa. She's going to talk to us about key considerations for implementing responsible AI. Now, Alyssa is the Director of Partnerships and Market Development at the Responsible AI Institute. It's a community-driven nonprofit organization working to advance trustworthy, safe, and fair AI with a first-of-its-kind certification program. With over 12 years of experience in business and partnership development, primarily in emerging tech, Alyssa has a strong understanding of the opportunities and challenges associated with the adoption of innovation tools and services. Recognizing that people are at the heart of these technologies, she has been successful in supporting both individuals and companies through various aspects of digital transformation. All right, I'm super excited to bring up Alyssa to our virtual stage here. Hello. Welcome to the DATAcated Health Conference.
Kate, thank you so much for having me. Super excited to be here. Thanks to everyone online as well.
Absolutely. I'll let you take it away. You let me know when you want your screen shared. I'm going to hop off for 10 minutes and I'll be backstage and I'll be back with questions.
Amazing. Thanks, Kate. Thanks everyone for having me today. I'm really excited and passionate about the topic of responsible AI, especially in health. I just, there's a lot of AI is having a moment right now. It's really hot, and the opportunities for AI in healthcare are exciting and enormous. So what we're seeing in predictive diagnostics, personalization, the automation and efficiencies that can be gained in the healthcare system around decision support and other things, it's really an exciting time to be in this field, and I'm very optimistic. However, I'm enormously cognizant of the fact that there are very serious and significant ways that unchecked AI can cause harm. So lots of examples of this have been happening for a number of years, and there's a lot of great strides that have been made by companies and organizations, but I'm sure you've all seen examples of racial bias and, in terms of triaging and preferring white patients over Black patients for complex care. Most recently, chatbots for mental health that are using ChatGPT without notifying users have been top of mind in terms of how are some of these new and emerging technologies looking or serving software as a medical device. And, previous conversation, lots of examples in the insurance context to cut or extend healthcare benefits using AI algorithms. And so while there's all these enormous opportunities, I'm very aware of the types of things that can happen if this goes unchecked, because harms do happen in different ways. I think when people think of things that happen or can go wrong with AI, they're often thinking about nefarious or bad actors. But I'm most concerned about the unintended harm. So harms arising from AI systems behaving in ways that you might not have intended. And so medical decisioning supports that potentially make the wrong call that wasn't necessarily trying to cause harm, but at scale could definitely be a very significant impact on these communities. And then there are intentional harms, and I use that word in quotes, but as we all know, there are trade-offs or risk-taking that can sometimes happen with AI or malicious uses of AI even. So one example of this is decisions with self-driving cars. Those algorithms and those technologies are going to have to make a decision about whether to protect a driver or pedestrian. This is a known harm. This is an intentional trade-off that needs to be considered. And then especially in the healthcare context, I'm very aware and considerate of the systemic harms. And so the unintended consequences from deployment of technology that shape the broader environment in society. And so when the Responsible AI Institute looked at this problem and they looked at the fact that this was such an emerging landscape, they realized that putting practical guidance in the hands of practitioners is the way to be able to start to create the systems, processes, and guidance to help organizations and individuals understand how to implement responsible AI at scale. And so we use the definition of responsible AI as the practice of designing, building, and deploying AI in a manner that empowers people and businesses and fairly impacts customers and society, allowing companies to engender trust and scale AI with confidence. I think starting with a definition is super important, so it's not ambiguous and in the ether. I'm going to ask Kate to share my slide. And so what we've developed is based on the international principles that have been pretty well established. The principles are clear and the foundations of what responsible AI should look like have been well debated and well established. What we're fitting and trying to do is create the implementation guidance and the dimensions of responsible AI that need to be considered to look at it holistically. One of the things we're seeing in the market and generally around this conversation is there tends to be an emphasis on one or two of these dimensions of responsible AI. So bias and fairness gets a lot of attention, explainability and interpretability as well. But a holistic view of responsible AI from an implementation perspective is data and system operations, explainability and interpretability, accountability, consumer or member protection, potentially in the healthcare context, bias and fairness, and robustness. So when we're thinking about this, it's who needs to be at the table to guide these conversations: industry experts, policymakers, academia, and definitely the end users, and testing it on key use cases in healthcare, human resources, and financial services. You can take it down. Thanks, Kate. And so when I talk to organizations all day about how they're approaching this responsible AI challenge, and what's happening in many organizations, and not always, but some of the current industry approaches are not working. I'm seeing a lot of concerns around potentially accruing a technical debt and being unprepared for what's coming in terms of regulation. There's a myopic focus, just to my previous point, on one area of AI, and there are other areas that are creating risk or exposure because they're not looking at AI holistically. And generally, one of the things that I think is happening is things are not scaled. So certain business units, functions, or products may have areas of maturity as it relates to responsible AI, but critical business functions like procurement or human resources are often overlooked, and they're not being scaled consistently across a large organization or even sometimes a small organization. And then people are not communicating about the responsible AI efforts internally or externally. I mentioned this off the top, but the fact that AI is having a moment right now, first time my mom and dad have ever asked me about my job, you're going to see more and more organizations actually communicating what they're doing externally because the consumer demand is there. And people are really starting to understand that there's going to be a need to have transparency, how people are using AI and deploying it within their organizations. Because in the absence of all these things, and obviously there's regulation coming with the EU AI Act and sectoral regulation, but even in the absence of a lot of those things, lost revenue as a consequence, lost trust in customers, and then there's lots of large legal fees and lawsuits that are actually hitting the headlines recently. So the leaders are in the industry and in the health industry are doing certain things. They are conducting assessments, whether they're building their own AI internally, buying it, or even potentially being a supplier of it. They're conducting these assessments to get a baseline, to understand where their gaps are, and to be able to communicate this to their potential clients or customers. They're very closely tracking regulations and standards, and they're proactively preparing. At this point, I would say it's reactive. If people don't have something foundational in place, they're likely going to have a challenge with that technical debt piece. They are scaling to make sure best practices are expanded, consistent, and communicated. And they are really endorsing and communicating their commitment and approach to responsible AI to stakeholders, internal and external. It's becoming a huge talent retention and attraction piece as well. And so what we realize is that responsible AI is a maturity curve. A lot of people have very strong responsible AI implementation at an operational level, but there's always opportunities to level that up. It starts with strong corporate principles and values. If responsible AI isn't at the table with the executive or the board around operating principles, corporate principles, ethic principles, or even ESG, it's really going to be a challenge to put responsible AI practices throughout the organization. And then you develop AI principles. I don't think there's such a thing as responsible AI principles. I think there are AI principles that are built responsibly. And then the implementation level, where strategies, measurements, tactics, work streams are really put through. And 10 minutes is a very hard time to talk about such a wonderful and meaty topic, but it really does have to start at that level, at executive and corporate level. And so the best things, I know I'm right at time, the best things to do are really align with an internationally recognized approach to responsible AI at a corporate level. This is, going to make compliance easier. There's going to be the best implementation guidance, and it will offer interoperability across supply chains, divisions, and jurisdictions. Whenever possible, there are already risk frameworks in place. There's privacy frameworks in place, ethical frameworks in place. This does not need to be a recreate the wheel exercise. Really, it's about uplifting existing organizational processes and governance and embedding responsible AI into things that already exist in terms of policies, processes, and tools. And then it's really that once that foundation is built, that understanding of what responsible AI means to organizations, incorporating it in all areas of the organization, HR, procurement, different products, training frontline staff, and understanding when they may be using AI as a clinical decision support tool. And then understanding the digital risk profile and agile governance to adapt when potential AI issues happen, or when emerging technology really upends everything and we're grappling with people using ChatGPT in their day-to-day. So those are new challenges that are happening all the time. Really, thank you so much for your time. Really excited to always have these types of conversations, and hope that gave some practical thoughts or guidance to consider around where to start with responsible AI.
Absolutely. Alyssa, thank you so much. Very interesting presentation. And I agree, 10 minutes is not enough. We might have to have you back to talk more. I can feel the passion you have for this topic, and I know you want to tell us everything. I love it. Thank you so much. Lots of great points here. I think AI is having a moment, which I love how you explained that. You mentioned something about regulations, and I wanted to sort of get your sense for, do you think we need more regulations in sort of encouraging, with maybe a penalty or something along those lines, corporations to act more responsibly with AI?
That's an interesting question, and it's a big question. So generally, I always love when I talk to organizations that like, we're doing this because this is the right thing. So more of the carrot than the stick. However, the reality is that in the absence of regulation, people are maybe not going to comply, especially within a timeline that is going to protect people. There are regulations that are coming out, or, the EU AI Act is going to look like the GDPR of AI. So you're going to see a lot of people complying to the EU AI Act, even if potentially they're not even operating in the EU. They're using that as the baseline for regulation. In the US context, I would say that the regulatory conversation is a little bit more behind. There's been some good guidance from the AI Bill of Rights from the White House, and there is, interestingly, good sectoral guidance. So software as a medical device and certain things in health that typically tend to be more regulated anyway. But generally, I'm very pro-regulation in a way that has been developed with industry input, because we don't want to hinder innovation. We don't want to make it impossible to use AI, but we do need guardrails. And so generally, I think it's not an easy conversation. It's taken years and decades. And, thinking about how things like large language models, or how we're equipped to deal with those from a regulatory context, is still a meaty topic. So, yeah.
Thank you for that. We've got a couple questions here that just came in. So I'll start with Ben. He's asking, what ways do you think we could educate providers and clinicians using some of these AI-powered healthcare tools to understand the benefits and limitations of the technology?
My experience in this context is as hard as it is, I understand the realities of getting frontline clinicians and other people that have full-time jobs involved in AI development process. It's very hard to do, but the best way that I've seen support, trust, and buy-in in terms of getting people to understand these things is involving them in the development process, defining the use cases, defining understanding the benefits of it and potential pitfalls, and then having a champion within that group to be able to do so. Not always the easiest task, but the more that they are involved in the process development and implementation, the more they will understand it. It will have less fear, and they will understand that it's meant to serve them. And they will also be able to understand when things are going awry, and then they can signal potential risks. That's really the easiest way. And then having, people that are on the front line that can advocate and support their colleagues and being able to articulate this in a language and in a translation that makes sense to them. I think the translator role in AI is very, very important. Talking to clinicians about confusion matrices and chat plots, probably not as helpful as talking about impact and outcome. And that's a really important piece.
Mm-hmm. Thank you for that. So you mentioned large language models, and Jorge had a question that they're developing so fast that it's impossible for healthcare practitioners to be adapting with it with enough knowledge at the same pace, I guess. What are your thoughts on that? Do you think we'll get there?
Yeah, I think honestly it is evolving. It came out so quickly. It became so hot. I definitely think that there's going to be more understanding on how to use this and when not to use this. There's still a lot of concerns around accuracy, privacy, even the environmental compute of it. And so you're seeing certain organizations and financial institutions, for example, are banning it altogether. I think that's an overcorrection probably. And I think that's probably just because they don't know how to handle it right now. And you're going to see a lot of guidance come out around large language models and these types of interfaces. But right now, I think people are just wrapping their heads around it, understanding how it can be used and the impacts. But there will be policies and processes, I'm sure, going out in a lot of organizations. And it's something we're considering as well, which is what's the practical guidance on how to use these tools? Because we do talk about lawyers, doctors that don't use AI are going to be left behind. So that's also a big part of what the type of practical practitioner guidance we're trying to develop.
Right. Awesome. Well, I know we're almost at time. I just wanted to give you a minute or two to talk more about responsible AI, the work that you're doing there, and what should folks do as a next step to follow you, to connect with you on LinkedIn. Tell us more.
Yeah, absolutely. So Responsible AI is an independent nonprofit. It's completely member-based, and we're working towards the first formal certification of AI systems. So a trust symbol that allows people to not only assess, but audit their AI systems in a way that is supportive of practitioners, but also is going to help them be compliant with the forthcoming regulation at both a national or sectoral level. Everything we're doing is to try and help implementation be streamlined, helpful, and light and low touch, and increasing the maturity of our member organizations so they're ready to meet all these AI challenges and opportunities in the market. You can find me on LinkedIn. I, like the previous speaker, I probably am the only Alyssa Lefebvre-Schkopitz. And please,
that's probably true.
And please do follow the Responsible AI Institute on LinkedIn and Twitter and sign up for our newsletter. But if there's ever interest in becoming a member or learning more about membership at the Institute, don't hesitate to reach out to me on LinkedIn.
Awesome. Well, Alyssa, thank you so much for your time here. And yes, everyone, go ahead and check out Responsible AI. Thank you so much. I'm going to move on to first providing the giveaway, and then we're going to move on to our next speaker. So I will share my screen. The hashtag to use was #Bootcamp. So I'm going to go ahead and put that up on our screen here. A quick reminder that this is provided by Data Career Jumpstart. So thank you again, Avery Smith, for providing this $2,000 bootcamp. We're going to select one winner. So go ahead, get your hashtags in there. If you're new to this conference and you just dialed in, don't know what's going on, all you have to do is type in the hashtag bootcamp into either LinkedIn, YouTube, Twitter, Facebook, or Twitch. And then you'll be able to enter. I'm going to click draw in just a second. So Data Career Jumpstart is 100% project-based and teaches you skills like the data skills that you would expect to learn, like Excel, Tableau, SQL, but also teaches you how to build a project portfolio, grow your network, and actually get a job in data. So I'm going to go ahead and click draw. Good luck to everybody. If you see your name there and you are a winner, it will be very clear that you've won. Just go ahead and contact me on LinkedIn and I'll make sure I provide you with access. All right, Michelle, congratulations. Woo! Just shoot me a note and I'll make sure that I provide you with access. All right, we're going to go ahead and keep this data party moving. I will introduce our next speaker. Here we go. Please help me welcome Anne Alvarez. We're going to tell you a little bit about her and then I'll bring her on. So Anne's going to talk to us about the health connection of volunteering. Anne has worked with data at healthcare organizations since 2018. Prior to that, she worked in a college preparatory program with youth traditionally underrepresented in college and then supported individuals with disabilities to find and maintain community employment. She recently completed her master's in health informatics and is looking for her next opportunity. So if anyone out there is hiring, you know what to do. You'll know where to find her. Because of her lived experience with poverty, the social determinants of healthcare are an area of focus that she cares deeply about and has seen how volunteers can actually make a difference in that area. She's a volunteer with Results, an anti-poverty nonprofit, and is one of their experts on poverty who will convene in Washington, D.C. this June to meet with members of Congress and their staff regarding anti-poverty legislation. She believes in volunteering and she believes that it can change the world. She's grateful for her children who helped her change the world. I'm going to go ahead and bring Anne up on our stage. Anne, thank you so much for being here. And I can't wait to hear your story. I can't wait to hear your journey. I'm going to hop off the stage here and let you take it away. I'll share your slides up as well whenever you're ready.
Okay, great. Thank you, Kate. I appreciate it. And thank you everyone for being here. So volunteering is personal to me because of my lived experience. Volunteers that gave of their time and money changed the trajectory of my life, but more importantly, of my children's lives. So volunteering is just a way of life for me. I want to give back because I have not forgotten. So we're going to look at some data. This is the kind of data when you find it, you crush on it and you wonder where it's been your whole life. It's from the AmeriCorps, which is the United States Federal Agency on National Service and Volunteerism. And they break down volunteering into formal and informal. So formal is like sorting donations at the food bank, volunteering with the homeless. And informal is like bringing food to your neighbor. My neighbor does that. She's a great neighbor. Or even something like writing notes of encouragement. So this data really captures the pulse of how our communities are doing and the engagement. And Carrie already defined volunteering as just a service without financial compensation. So this slide is some of the data. Turns out doing good is actually good for you. And one of the benefits of volunteering is mood improvement by 93%. And I think that's great odds. Another one is lowering stress levels by 79%. And also this picture is my city, my community, Salt Lake City, Utah. And I hope by the end of our time together that you will see ways that you could be involved in your communities, which benefits your health and benefits your communities. So I know some of you already volunteer, and some of you have thought about volunteering, and others think it's not for you. And that's okay. I just hope that you consider the possibilities. And another benefit of volunteering is it gives people a sense of purpose and it expands your worldview. And friendships are made. 3 of my dearest friends I made while volunteering. So let's look at more of the data surrounding what age groups are doing volunteering. And I think it's great to see there's a lot of informal volunteering going on, which means we're talking to our neighbors and engaging. The highest rate of formal volunteering is in the 45 to 54 age range, which agrees with the data for my life because I'm in that age range. And there's also opportunities to volunteer if you have children. My oldest son and I started volunteering at the Utah Arts Festival when he was 12, and we volunteered until he grew up. And we had a lot of fun. And he now works as a computer programmer for an ed tech company. But let me tell you more about my kids. It was December and it was cold and snowy, and my baby was 4 months old and my toddler was 2 years old. And the motel room we were staying in had stain, torn curtains, and grimy red carpet, and a faulty heater. But there was a swing set that had one working swing. So I would take my boys out, bundle them up, and push my oldest in the swing. And he was happy. And then life threw us quite the plot twist. From there, we ended up in a long-term women's shelter. And the volunteers that would come and visit us were just a bright light in our lives. Prior to this plot twist, I had worked for the same financial company for years. And after a layoff, I had started a successful catering business. So some other data is just the economic value of when we volunteer. I don't have my glasses on. Oh, almost 23% of Americans are volunteering. So like, good job. And that's $123 billion in economic value. And another thing is to consider if you have corporate volunteer hours, to use them. 26% of companies in the US offer them. And so I have a favor. If you have access to those hours, use them. Ask your teammates, let's do this. So my last slide is some data points from my life. It's my fridge. I think what someone has on their fridge says a lot about them. The Get Lost in Montana green sticker I got when I visited my son who was doing conservation work on the Continental Divide Trail. He's an arborist now. The Continental Divide Trail goes through some of the national parks. And did you know you can volunteer with the national parks? You can do it as an individual, as a group, you can do it for a day, you can do it while on vacation. So that's a good resource. The red magnet is from the New York Public Library. I got that when I was visiting my sister. And if anyone in the New York area that knits or crochets, they're looking for volunteers. And the last thing I want to look at is the sticker that says Humanize the Homeless. That's from a book called 50 Sandwiches, and they interview people who are homeless and tell their stories. And it also highlights the fact that when you are volunteering, you do work with marginalized communities often, and you want to look for the humanity in them and find that you do have things in common. And a recent experience I had, I think, illustrates that well. I was volunteering at one of the pop-up shelters that we have in our city, just on nights when it's extremely cold. And one gentleman mentioned that it was his first time at this shelter. And I asked him, how was it? And he said, first of all, I'm really grateful for what the other shelter has given me. But tonight here, I felt welcome. I felt like I belonged. And I love that. And my hope is that you will connect with your communities through volunteering. whether formal or informal, and just consider the possibilities. And then I want to give you a behind look on how I prepare for talks like this. I like to do art because it helps me remember. And that's just a fun fact. So again, I loved being here, and I just thank you for this opportunity.
Awesome. And well, thank you so much for sharing your story, and thank you so much for inspiring others to look into volunteering. First, I'll start by saying I have nothing on my fridge, so I'm not sure what that says about me. You actually made me think. I'm like, huh, but I have nothing almost anywhere. I'm more of a minimalist, and I don't like things. I do have stuff behind me. That's pretty much all I have. But I really want to thank you for this. I want to ask you what advice would you give to others if they're inspired and they want to get started, but they're not sure where to volunteer? Because a lot of times it can be intimidating where you don't know where to start. I remember when I got into volunteering, I went to an organization called New York Cares or NYC Cares, and they had all of their volunteer opportunities. They outlined by location, by date, and it was so easy to find, and I loved it, absolutely. So I was wondering if there are other websites that you'd recommend or any locations, libraries, like where do you think people can start?
I recommend, if you're looking locally, there's traditionally a United Way in every state. And if you go to your state's United Way website, they'll have options. Another thing that became more apparent during the pandemic was virtual volunteering. So places like Volunteer Match have examples, and that's how I got hooked into doing some career counseling virtually with United States veterans. So I think if you're more interested in virtual, there's opportunities out there too. And I think look for things that are your strength and that you would find enjoyment in.
Oh, I absolutely love that. I didn't think about virtual. I think that's a great approach, because a lot of us are like, oh, I might not have time, and how do I get there? But we do have skills, especially data professionals. We have skills that we're able to leverage virtually, and I think that's a great idea. So you mentioned, in the bio, we mentioned that you are open to new opportunities, and I think this is a good place for us to just bring a highlight to that, and maybe tell the audience what's your ideal role look like, and what exactly you're looking for, because someone might know someone that can help you land your dream job.
Yeah, I appreciate you bringing that up. I'm interested in work that deals with the social determinants of health. To work with homeless data would be like a dream come true. I like the troubleshooting side of data. I like to figure out why it's not working and make it work. So I'm looking in the nonprofit sector, human services, government agencies. I just want to work with data. I just want to play it. So.
I love that. I just want to work with data. Okay, well, awesome. Thank you so much. And I took a few notes. So volunteering helps you improve your mood, your self-esteem, lower stress, and get better physical health. So just a recap there for folks who are looking into starting to volunteer. And I want to thank you so much for joining us here at the DATAcated Healthcare Conference. And we'll see you online. Everyone, I encourage you to go ahead and connect with Anne on LinkedIn. Anne, is there another place where you want people to go and connect with you?
LinkedIn is great. Thanks for asking.
Okay, awesome. Well, thank you, Anne. Have a great rest of your day. We're going to go ahead and keep this data party moving. I'm going to go ahead and bring up our next speaker. First, let's start with some introductions. We're going to hear from Ben Moore, and he's going to talk to us about PH farming through data, effective storytelling through healthcare's diverse ecosystems. Ben Moore is currently the pharmaceutical data analytics coordinator at St. Jude's Children's Research Hospital. He graduated from Lipscomb University College of Pharmacy and completed PGY1, PGY2 informatics training at LifePoint Health in Nashville, Tennessee. He is a pharmacy informaticist specializing in data analytics. He holds a master's degree in healthcare informatics with a passion for improving the medication use process through data-driven decision-making. His interests include Microsoft Power BI, SQL, and Python. All right, Ben, I'm going to bring you on. You're going to tell me what PGY1, PGY2 stands for. So let's go ahead and start with that. Welcome to the DATAcated conference, Ben.
Hey, Kate. It's great to be here. Super excited. So all the speakers have been great so far. PGY1, I think it stands for postgraduate year one. And so kind of like medical students, pharmacists kind of can do residency programs after college. So.
Okay, wait, what does that say on your whiteboard?
Oh, I tried to, in the best handwriting possible. I have really bad handwriting. Just hello, DATAcated. So
that's what I thought I saw. Awesome, I love it. All right, so I'm gonna hop off the virtual stage here. I'll let you take it away. You let me know when you want your slides up, and I'll be back in 10 minutes with questions.
Awesome, sounds good. You could just go ahead and throw up the slides. That'd be perfect. So again, hello. Super excited to be here. My name is Ben Moore, and I'm going to talk about 3 practical ways that we can help ease the burden through farming, through healthcare's data ecosystems. And so I love a good pun, so I always have to throw in a pharmacy or farm play on words whenever I can. So from my 4 years of working at St. Jude, I've really experienced a lot of growth and learning from being a pharmacist, but sitting in a non-traditional informatics role as a data analytics coordinator. And so I always like to highlight St. Jude, very passionate about the organization I work for. So it is truly wonderful. It was founded by Danny Thomas, actor, singer in 1962. And so located in Memphis, Tennessee, with the vision that no child should die in the dawn of life. No patient is ever charged for treatment or services at St. Jude, which is great because it really allows us the resources to be able to solely focus on providing the best possible care for our patients every day. So just a little plug for St. Jude. So let's jump right into it. So this is a diagram of our medication use ecosystem. Big takeaway here, you're probably all aware that healthcare is very complex. Caring for patients is very complex, especially with children with catastrophic diseases. It's resource intensive, and oftentimes our healthcare systems utilize a lot of different software and technology to be able to provide the best possible care for our patients. And so this diagram is specific to just our pharmacy department. So just to call out some of the different technologies here, you can see our EHR is a big part of this diagram, our electronic health record, where a lot of the data that we use in our analytics comes from. But pharmacy and healthcare is a lot more than just the electronic health record these days. And so we have our automated dispensing cabinets where we actually store the meds. We have our retail pharmacy system, which is also connected to our EHR. I would argue honestly that healthcare really might only be second to aviation in terms of regulatory compliance, auditing, and different accreditations that we have to go through. So a lot of these additional software solutions help with regulatory compliance. And so we have our wholesaler data coming in, where we buy the drugs. We also have clinical content vendors, which help provide our medication rich data points. And then we also have 340B and a bunch of various ancillary systems like infusion pumps, where our kiddos are able to get IV treatment, as well as all the way down to education and education resources for our patients about their medication. All that to say is the number one takeaway here is, do you know the interplay in your healthcare organization between different software solution and vendor products? And so really I would advocate for you to diagram out your specific healthcare processes, your different workflows. For us in the pharmacy department, it's our medication use process, where we all the technologies involved from when we buy the drug all the way through storing the drug, prescribing, dispensing, administering to the patient, and then ultimately destruction or waste of additional drugs. And so by diagramming out all the different interfaces and interplay, you can really start to easily discover gaps available in the data that might provide useful for doing additional analysis. And so diagramming your technology and the interplay, especially in healthcare, super important to advancing your analytics and furthering telling your story. The second point I wanted to make is, and I think this is really unique in the healthcare space, is bridging the gap between a traditional IT analytics team and the healthcare providers, the frontline staff. And so, collaborating and communicating between our IT teams and our healthcare providers honestly can be challenging. They don't teach data concepts in medical school, let alone pharmacy school or nursing school. And so a lot of these terms that we throw around and use in our day-to-day jobs and lives are foreign to a frontline clinician who's very focused on providing the best patient care possible. And so the second point I would advocate for is the role of an informaticist really is invaluable to help bridge the gap between your clinically trained staff and your analytics team. And so, our IT teams, we think of maybe less operational knowledge, the day-to-day workflows, but very high technical skills, able to pull data out of those systems and report very effectively. Whereas our clinicians, you have high operational knowledge. They know the workflows, they know the front end tools, but their technical skills might be a lot less than that. And so the role of an informaticist is really to help bridge that gap and be that data interpreter, that negotiator between the requests that come from frontline staff of hey, I need this new fancy dashboard to measure turnaround time for first dose antibiotics given out of our emergency department. You might have your IT team folks being like, I don't even know where that data lives, let alone creating a custom dashboard. And so I would really advocate, you're already probably having folks in your organization play this interpreter role, even though it might not be a described in their job title or as part of their job function. And so really, leaning into the people that are doing this job right now and seeing, how can you better support or open up the lines of communication between front end staff and your central analytics team. And so, no matter what healthcare system or company you're part of, the third point I want to make is always a need for, really good, rich dimension tables. And honestly, the first step of having a good backbone of your different technologies, data, and having it flow into, whatever data lake, data warehouse your company or organization uses. A very practical example here is, a typical hospital might have 5 different software solutions that call similar medications by different names. So a common med we use here, it's an antiemetic, anti-nausea pill, Zofran, ondansetron, but it might be called various things throughout our different, healthcare technologies, like our EHR, our automated dispensing cabinets, our dose preparation software. Even our clinical trial software might call ondansetron a little bit differently. Even differences in how the dose and dosage form is displayed. And so one of the things we did at St. Jude was we started to collaborate to provide and establish a standardized medication table that standardizes medication grouping and categorization across different departments and even our different technologies, which became vitally important to effective end user reporting across different departments as we're sharing dashboards across the billing department and the clinical department and our clinical trials research department. Calling ondansetron by the same name, there's a lot of power in that as far as doing roll-ups and different visualizations and analytics. So just hone in on this example real quick with just some example fields you could start to use for a standard medication table. So we standardize, RX name with the strength and form. So like ondansetron 8 milligram tablet. Then having a really rich, simple generic name of just ondansetron was vitally important. Standardizing between therapeutic classes, and then having like a roll-up subclasses, having that rich, grouping, vitally important to end user reporting. We also added some external medication data sources, so like generic product indicator, RX norm codes, and DC codes, which really allowed us to easily bring in external medication data for more rich descriptive reporting. And then we even added some site-specific medical fields like hazardous drug class, opioid flags, and antimicrobial flags for antibiotics. And another great one that I left off here is, non-formulary flags. So any medications that you don't want clinicians to be able to order, oftentimes it's a very rich field that you can add to a standard medication table to allow, very easy formulary compliance reporting. Again, all this, which really aids in doing more advanced analytics and then eventually training, some machine learning models. The more descriptive, discrete data fields you have, the better models you can produce and provide outcomes for. So again, just to summarize, 3 practical ways to help ease the burden of farming through healthcare system data. 1, diagramming out your specific medication use or healthcare workflow process. 2, championing for the informaticist role in your organization to help bridge the gap between IT and clinicians. And 3, exploring standardized dimension tables to make end-user reporting and advanced analytics easier between multiple disparate systems. And thanks for having me. Love to take any questions.
Awesome. Thank you so much, Ben. Wow, some of those slides just reveal the level of complexity that organizations have to deal with. And we've got some questions coming in from the audience, but I wanted to start with sort of your tech stack, your tool stack. What are the tools that you personally use within that ecosystem of architecture in working with data?
Yeah, so a lot of it's governed at our institution level as a whole, and so we're really involved with as Microsoft Azure being our cloud-hosted solution for our data lake. Then we utilize Tableau and Power BI for end-user reporting, and then as well as a variety of other tools. That way we can integrate, Python or R scripts and help, further clean our data as it's coming out of all these different, healthcare software solutions.
Right. Thank you for sharing that. We've got John in the audience saying that language is the linchpin between highly technical resources and operational expertise. And the question is, can we use operational glossaries to connect them?
Yes. So definitely, having a data catalog is something that, is not a super, like sexy term or whatever, but it's so important. And so we are about to implement data.world here at St. Jude, which is just a data dictionary vendor. We have a data dictionary specific to our EHR that is maintained, but that is something, even with any end user reporting, I make a point to, attach a data dictionary that spells out the metrics and how they're defined, just in case, anyone comes across, a dashboard and has a question on, how is pharmacy turnaround time? What does that even mean?
Right.
There's a document linked straight there that they can go see how it's defined.
I can see that being extremely helpful for people who are just confused looking at something. Awesome. We've got a question here from Jacob. He says, Ben, having come from the clinical practice side, what has been the most impactful practice in gaining and understanding in your informatics skills?
Oh man, that's a good question. Honestly, it was I would say always being a lifelong learner. So coming into a role where, I wasn't trained to be, honestly like a data nerd. And so having to, attend talks like this and trainings and, do a lot of self-learning, as well as not being afraid to, reach out to our central analytics team here at St. Jude and say, hey, can you just show me like, how do you create this data pipeline? Or like, never being afraid to ask a question of like, what is a data pipeline, in meetings and really speak up to show that you're interested really helps gain the buy-in and establish those relationships between the clinical staff and the analytics IT team.
Awesome. Thank you. And John actually had a follow-up question. Would you say that a data glossary and data dictionary are equal or not?
Yeah, depends on your organization, right? So glossary, healthcare, it's an alphabet soup, right? We have acronyms for everything, especially like diagnosis, medications. And so, yeah, I could see, having like an end user glossary that's just a very high level. This is what this means,
Right.
and then a data dictionary probably being a more technical back end tool that users could ask if they had additional questions.
Mm-hmm. And I really loved your graphic where you showed the technical versus non-technical users and sort of that bridging the gap slide. I wanted to ask, what have you seen? Are you seeing progress, I guess, in terms of are we actually bridging the gap? And if yes, which I'm hoping you'll say yes, because if not, we're moving in the wrong direction. What do you think is impacting that? Is it more people being more interested in becoming data literate, or is it the tools and technology making it easier for those who are non-technical to understand sort of that technical side? So I'd love to hear your thoughts on that.
Yeah. We recently had a consulting group come in and they really helped us restructure our whole like data analytics program at St. Jude. And so they were really focused on the center of excellence model. And so empowering super users within each of these like departments, whether you're pharmacy or nursing or clinician services, to gain more access and work more closely with the central analytics team. And so by doing that model, we have kind of super users or, these centers of excellence spread out across our organization that are, highly in communication with our central team. And that model has worked really well because before we were more like siloed or I'm going to enter in the ticket if I need something versus we just have like an ongoing relationship and dialogue. So.
All right, awesome. And we had a comment here from Jorge saying, building a complete data dictionary is likely the minimum that a data analyst must do in order to get valuable inferences from data. And I'm glad to see that you guys are, moving with the data.world model and really making sure that whenever folks have questions, they are enabled and empowered to get those questions answered. So my question on this is, how big of an effort is this? Is this like a massive project that's going to take months, or is it? Yeah. Okay.
Yeah. Right. I mean, so, we're kind of going through the initial governance of, what is our policies going to be around, end users creating something. Obviously, the data dictionary is only as good as the data that's put into it, so who's going to be the data owners?
Mm-hmm.
Who's going to kind of enforce of you have this, end user report, you've got to fill out the dictionary. So garbage in, garbage out. So
we need a dictionary, or goodness in, goodness out. If
That's
Scott
right.
Taylor's in the audience, he would have been typing that right now. We want to focus on the good here, Ben.
That's right.
So, Ben, I really want to thank you so much for taking the time here to provide a presentation, teach us something new, and answer some of our questions. So I really, really appreciate that. We're going to keep this data party moving. So make sure you follow Ben on LinkedIn, or is there any other platform, Ben, that you want to shout out?
LinkedIn's great.
LinkedIn's
Ben
great.
Moore. There's a lot of Ben Moores, unlike the other presenters. So Data Nerd Pharmacist, that's will be under my name. So
Ben Moore at St. Jude. All right, good to know. Thank you. Yeah, I'm the only Kate Straszny, I think, maybe in the world. I have tried to Google myself. I have not found another Kate Straszny out there. So, all right, we are going to keep this data party moving. Now, I'm going to go ahead and introduce our final speaker for the DATAcated conference. It actually went by so fast. So I'm gonna bring on Josiah Petgrave, she's gonna talk to us about a data-driven approach to improve the quality of care delivered and health outcomes. What a great talk for our final session. Josiah is a health analytics leader at Ontario Health. She is a seasoned analytics professional who has honed skills in data insights, storytelling, and visualization to provide insightful recommendations and drive data-driven decision-making. As a health analytics leader, she has a proven track record of leading cross-functional teams to deliver cutting-edge analytics insights to improve health outcomes and reduce variability in care across the province of Ontario. During this talk, she will reveal how to leverage analytics to drive better outcomes. All right, Josiah, I'm going to go ahead and bring you on here. Hello, hello. Welcome to the DATAcated Health Conference.
Hi, everyone. I'm so happy to be here.
Great to see you here. So I see your slides are up. I'm going to hop off and give you the 10 minutes. You just let me know when you want me to share your screen, and we'll go from there.
Yeah, I think we can start rolling. Okay, great. Hi, everyone. As Kate mentioned, my name is Josiane Petgrave, and I'll be talking to you today about how we can really leverage health analytics data to improve better outcomes. So I like to set the stage with a story. I'm very reflective, and my life experiences really inform some of the approaches that I take as well. So I want to share something with you. So in 2019, my husband and I decided to backpack with my 11-month-old. And you would think that the real challenge was trying to figure out accommodation or figure out our itinerary, but it essentially was trying to figure out how can we condense all our essentials into 55 liters. And it was quite a challenge. And so what we did was we went to the University of YouTube, as we always do. And some of the interesting feedback was roll or fold. Use packing tubes, which was very great. And my best one is wear what you can during check-in. So that's essentially not very feasible. But the talk that I want to have today is going to focus on the province where I live. So essentially, we are on a journey when we're in the healthcare system on how we can essentially pack all our needs and preferences to serve the population within our catchment area and what our system relies on. So in the province of Ontario, it's located in Canada. I'm not sure if we have any Canadian audience members here, but it's the biggest province in Canada, 14 million people and 38% of the country's population. And so we're trying to figure out within the context of my healthcare, or the healthcare system that I support, how can we serve these 40 million people with very unique skills and experiences? So the way the province's healthcare system is designed, it's designed into 5 essential regions and geographic regions. So they're geographic based. So what I presented on this slide are 2 regions within Ontario with quite diverse distribution. And it's just to reflect that it's not a one-size-fits-all healthcare system, and we really have to consider who we're packing for. So if we use that backpack analogy, what data elements are we bringing into our analytics sphere to really identify the needs of the population? So in central region, we have 5 million people. And in northern region, we have a little less than 1 million people. And you can see that the distribution across each region, you'd have 1% Aboriginal Indigenous people in central region, whereas there's 16% in the northern region. And when we look at the immigrant population as well, you'll see that huge disparity as well. So I wanted to really focus our conversation on this question, essentially. Why is having more data isn't helping us make better decisions? So we're in this phase of getting as much data as possible, but we really need to focus on answering specific questions, specific needs question on how we can support our healthcare system. So we need to really dive down to the crux of the issue. And the pandemic has really taught us a lot, more than we want to have a lesson in 3 years. But it really taught us that our healthcare system is quite dynamic, and it's not a one-size-fits-all process. Analytics can't be one-size-fits-all. It has to be adaptable to the context in which it serves. So it's very important to capture unique needs and preferences and factors that influences population health, the value that can be achieved out of the healthcare system related to health outcomes, the patient experience, as well as the provider experience. We can't leave out the provider experience as well. But I want to talk about how we can really revolutionize healthcare data and how we can leverage analytics to drive better outcomes. Health data is becoming more and more important as we continue to find our way to improve the healthcare system. And with the use of analytics, we can really extract value and create valuable insights, and we can make more equitable decisions and ultimately improve the overall population outcome. Okay, so this one is not visually, but it's supposed to show like packaging track, which really shows that we have various aspects that are feeding into our data. And what we really need to essentially focus on is maximizing the utility and to make data as granular as possible with frequent delivery cycles. So what we're having right now is that we'll have data lags in healthcare system because we are more reactive instead of proactive. And analytics can be a powerful tool to help us get ahead of the curve, get ahead of the vast amount of health data that's available. So it usually involves using statistical and computational methods to extract meaningful insights from platforms to identify trends, detect anomalies, and also to predict outcomes. But we can't just, we mustn't focus only on collecting and storing data. So I know a lot of the infrastructure is like, oh, can we collect the data, the most data from the patient encounter experience, and how can we store it? But we need to make sense of what this data is saying and essential to inform decision-making where it comes onto the healthcare system. And the most important benefit is that we have the ability to improve patient outcomes by analyzing patient data. Healthcare professionals can identify high-risk patients and intervene early and reduce the risk of complications and readmission. So essentially, we need to have this system that supports us to make quick decision-making. And I will share some of how my work and my role as the manager of data analytics with Ontario Health, how some of these principles have been applied in practice. So we have a program called the Quality Standards Program. So the Quality Standards Program focuses on how Ontario is performing with a specific clinical condition or clinical area. So if this is the gold standard, what is happening in Ontario? Where's the variability in care? What's the burden? And what are the risk factors this population is seeing? So essentially, data analytics is a huge and integral component of that program success. So we essentially look at the clinical area of focus, identify specific demographics, unwarranted variation either by geographic region, based on practice at the practice level, based on the institutional level. Essentially, we're trying to get at it doesn't matter where you seek care in Ontario, you should receive the same level of care. And so the intent of the program is to embed analytics into that topic prioritization because there's multiple aspects of the spectrum of care within a specific clinical area. And so it's heavily guided by guidelines and clinical experts in the topic prioritization. And then we set the standards and then we measure it. Then we have to set some measures so that we know that these are the measures that we'll use to support the successful implementation of the standard, raising the bar based on current state. We need to perform, we need to do better. And it doesn't matter what population you're serving, they should receive the same level of care. So to summarize, the measures, how are the measures identified and rolled out? So the first aspect of it is to understand the population. What's the demographic? What's the age range? Where are they living? How do they access care? Do they access care the same way? Do they experience care in the same way? And we understand that the data analytics world in health, and especially in Ontario, is evolving. Not everything is measurable. And if you can't measure it, we can't track it. And if we focus on everything, we focus on nothing. So we try to really be specific on what we're trying to target. And then when we identify the gaps and the variability in care, then we set some statements to say, this should not happen, and this is what we recommend, and this is how we can move forward to achieving the ultimate goal of reducing the variability, burden of diseases, and quality of care within a specific clinical area. So in doing this, sorry, I have some older slides. Sorry about that. So what I really wanted to show on my next few slides was to show some instances across the province where we have seen variability in care. So since I don't have those slides, I'll speak to it. So there's one instance where we saw, we had a hip fracture quality standard where we're trying to improve the care of the elder and frail population and the variability in terms of the type of surgical intervention to receive and the outcomes of the surgical intervention. So before the quality standard was set, we realized that there was a high variability on the blood transfusion rate And it was actually against evidence and guidelines to have blood transfusion during it wasn't actually best evidence to have blood transfusion during specific surgical interventions within hip fractures. And we noticed that certain hospitals actually had a high rate of blood transfusion. And we wouldn't have known that without the data. That wasn't an area that they thought that would have been prioritized. That wasn't something that they thought that Ontario was performing below standard. They had the assumption that it was common knowledge that blood transfusion is against best practice, is not necessary, and it actually can lead to severe complications. So what we did was we saw that variability across the institutional level, facility level. So depending on which hospital you receive your surgery, you may have a blood transfusion. And so the standard allowed us to really focus in on reducing that unwarranted variation at the practice level and improving care within the hip fracture quality standard. And the next example that I had was referring to surgical site infection. So we saw a distribution as well, the rate of surgical site infection across the province, and we wanted to reduce that variability. It doesn't matter where you receive your surgery, the likelihood of you developing a surgical site infection should not change, should be unchanged. And we understand that there's some noise and some things that we can't account for, but the best approach is to really try and figure out how we can close that gap. The gap between how we perceive the care is being delivered and the actual delivery of care. So the last slide. Okay. So the last slide, I wanted to kind of zone in back on that story. So getting back to that European adventure. So when we got there to our first destination, we was first hit with the fresh bread and the sounds of mopeds rushing through the streets. And we instantly felt the weight of the bags on our back. And exhausted as we felt getting there, we knew that the journey has just begun. So in the context of data analytics, getting more data and getting the right amount of data and having the right insights only takes us to the first step. We need to make a concerted effort on really pulling out insights on what's happening in our population and how we can improve the care that's delivered through data analytics, along with setting standards. Okay, and that's the end of my talk. So now it's over to you to put me in the hot seat and ask your questions.
You're in the hot seat. I love it. Thank you so much for this great presentation. I always learn so much, so thank you so much for this. Okay, first question, the 11-month-old on the trip. I want to go back to that. I have 2 kids and we traveled. We took cruises when they were small. But I want to learn more about this trip. How long was the whole trip for? And did you have a stroller? I think that's my main question.
So we had those 2 backpacks, the exact backpacks in that picture. And we had a stroller, umbrella stroller, which had a strap. So we had it on our shoulder. And then the baby was carried on us. Okay. At different times. So it was quite an adventure, but it was worth it.
Oh, it was worth it. Okay, that was my follow-up question. So I'm sure it was an adventure. And thank you so much for sharing that. You started off by saying more data is not going to be helpful. And John had a comment here. Is it because it comes with too much tech and the tech just doesn't process it efficiently, effectively, or what's the issue? Why won't more data help us?
Because it doesn't allow us to focus on the crux of the issue. So we need to have a strategy where we're looking at the right suite of data, the core set of data elements. When we have too much data, we measure everything. And it creates a lot of noise in the healthcare system as well. And it doesn't allow us to really zone in on the real issue. So with a strategic approach of having like a concerted, like a set of core indicators and core measures, it really helps us on to drive change and have a focus goal standard and move towards that goal of reducing variability and improving care.
Mm-hmm. Awesome. And you mentioned that not everything can be measured. We can't do it all, and I understand that. And there are things that we literally can't measure just because they're just not, we're not able to do that. So do you see that things are sort of falling through the cracks just because they're not easily measured? Do we prioritize projects where
Right.
it's easier to measure?
That is such a good question, and that is so true. Like the measurability of because we don't know what's happening if the data doesn't show it, right? So we think that an issue doesn't exist because we can't measure it. So a part of the work that we're doing as well is data advocacy. So I know I said more data isn't the answer, but the right amount of data. So maybe we need to like really focus on what we're looking at and what we're trying to measure. And when we see that there is a measurability issue, we actually do a data advocacy approach at the federal level, at the national level, where we get like an organization or group saying, okay, this is a clinical issue. And there's a gap right now. We don't know what's going on. We hear from patient experiences, provider experiences, that this is a real issue. And the data, that data drives change. Everyone loves to say, okay, let me see it in numbers first before seeing is believing.
Yeah.
So we do that data advocacy approach.
Okay, thank you. And then I guess a final question I had for you. So you mentioned the gap between what we perceive is supposed to be happening at these locations versus what's actually happening. So what actions are you taking besides looking at the data to see if the gap is sort of widening or shrinking? What are the actual actions taking place to shrink that gap?
Right. So that's a great question. So a part of the whole approach is an implementation and dissemination. So we have the data feeds into the standards, we set the standards, and know what? Right?
Yeah,
like,
exactly.
It's not going in air, right? So we need a whole dissemination and implementation approach. And that's a concerted effort to get the guidance and the standard into the hands of not only the providers, but also the patients. So we also equip the patients to be advocates for their own care and with data. So the patient has the data saying, hey, this is gold standard and this is not happening in my area, and I don't want this to happen to me. So we equip them with a patient guide as well as a provider guide to kind of have that conversation.
That makes sense. And, just from a personal perspective, consistency matters so much, that standardization of you go to place X, Y, or Z and you expect the same service, the same treatment for the same problem. It is not always the case. Even going to the same facility, you treated by a different provider, and they will have a different process. And I think the more standardization we can get, as long as that process is a good one, it's an effective one. We're not standardizing just something bad just to standardize. I think it's definitely a good goal to move towards. Are you seeing that we're getting there anytime soon?
So because it's so dynamic, right? The healthcare system, there's always something else that we need to focus on. But I do think this is the right approach. I do think that it requires a lot of resources in order to execute on. And I think we're moving in the right direction. And I think we have a good runway. We have a good runway, but I would say that there's a lot more work that's needed in this space.
Right. Absolutely. There's always more, always more to do. But Josiane, I really want to thank you so much for joining us here at the DATAcated conference. Thank you for the time it took for you to prepare the talk, to give the talk, to stick around for the Q&A. I really, really appreciate it. And I always learn so much from our speakers. So thank you.
Thank you. Happy to be here.
All right, everyone, follow Josiane on LinkedIn. That's where I found her. So that's where you can find her. Thank you. Now, I can't believe the time flew so fast and we are at the end of the DATAcated Health Conference. I really want to thank all of our speakers for all of the time and effort that they took for providing their presentations with us today. I want to thank all of the attendees who are viewing us live, or if you're watching the recording, thank you so much for your engagement. Thank you for your great questions. I truly hope you were able to network in the chat, and you can continue to do so after this live stream is over. I saw a lot of friendships being made in the chat, so I'm also hoping you learned something new today. I definitely did. And if you enjoyed the conference, if you enjoyed DATAcated, show your support. Just drop a DATAcated into the chat. That'll mean everything to me. So thank you so much. And again, I'll see everybody online. Stay DATAcated, and if you want to stay in touch, go to DATAcated.com. You'll see all the work that we're doing on there. You'll be able to see the upcoming shows, the events. So thanks again. Have a good rest of your day. Oh, I can take my healthcare coat off now. Bye, everyone.